Precongress.
Hello. Over. Mhm.
Ishan? Hello?
Yes, madam, very clear. Yes, madam.
Can you hear me?
Yeah, very clear, madam.
Okay, now I can hear. Okay.
Your picture is not visible, madam, but the audio is very clear.
Your voice is not clear. Something wrong with here, I think.
Okay, madam.
Can you see me?
Yes, madam. Clear.
Okay. Ishan, do we have something to display in that interval time? Break.
Madam, currently I have no nothing, madam, because I'm having only the post and the today's post and those things, madam. If there's anything, madam, I can.
And you have a segment of PCs in manual.
No, madam, Manga.
Maybe now this like what is it?
Hari madam. It is the madam.
ටික දාන්න. අර කැලි ටික.
Sure, madam, sure.
ඒ ටිකයි ලොකු එකයි දෙක ලොකු එක ගිහිල්ලා නිකන් ඒක PowerPoint kind of thing නේද?
Yeah, sure, madam. No problem.
Thank you. විශාන් අපිට මේ ඔක්කොම පැනලිස්ට් මේ ගණක කතා කරනකොට ෂොට්ස් ටිකක් ගන්න ඕනේ නේද මේකේ?
Oh, madam, එක කරගන්න පුළුවන්, madam.
මා ආයුධය Litma?
Yeah, madam. I will let.
Litma, I think she's there.
Yeah, madam.
Oh,
I am here, madam.
Litma,
I'm there.
we need to take some screenshots or a kind of from your phone, for mobile phone or something. With
Right,
the
okay.
like Dishan, can we ask like all three panelists to on their now the first one we can't, the
Yeah.
second one they all can on their videos, and can we take a kind of a photo, then everyone is now here like
Sure, madam.
myself here.
Sure. We can, madam.
Yeah. And you know, how many I attended one other virtual conference. ඒගොල්ලෝ කිව්වා now all of you on your cameras කියලා they took a photo.
Yeah, madam. That also can be done, madam.
That is for participants there.
Yeah, that is for the participants, madam. Attendees.
The panelists each and every segment
Yeah, yeah.
So shall we take like now the first one we can't because it's a recording.
Yeah.
Chamara is there, it's only one picture. Then the second segment starts, that we will be starting with the MRCP. First we will ask all three of them to on their videos and take a photo. Then the peer mentoring also will get one. Then once it's over, after the portfolio, we'll ask all the attendees to on their cameras and take a photo. Is that okay?
Yes, madam. But when it comes to the opening the when it comes to the opening the screens for the attendees, madam, because since this is a webinar, madam, they can't basically open their screens, madam, unless we promote all of them to panelists, madam. Yeah.
Okay.
Okay, madam. Thanks.
Litma, what I want is to take a photo. I will also try to take when there's a maximum amount of people in.
Right, okay, madam.
So then we
I
know how many are like.
Yeah.
Okay. So Ganaka sir is there. He has some time.
Hello, hello. Premali, good morning, madam.
Good morning. Ganaka, we want to take I myself and Dishan was discussing. So all the panelists, now for this panel, I don't know at what time Chamara will join. So you, myself and whoever. So we'll take one photo.
Yeah. That's a good idea.
And then each segment we will take.
So the first segment only Prof. Lekamasam and Chamara will be joining it, Premali.
Prof. Lekamasam recorded one.
All right, that's okay.
I will ask Chamara to join, then we can take a one.
Host has stopped video of mine. Dishan, magi video එක දානවද?
Yes, sir.
Thank you.
Chamara can join. Okay.
So you can on your cameras.
All right. Good. How is my virtual
Very
background?
nice.
හොඳයිද?
Nice. Very nice. Very nice.
ප්‍රේමාලි මැඩම්ටත් ඒක දාලා දෙමුද අපි?
Jealousy background එකක් තියෙන්නේ.
ඒක දාගමු.
එන්නාට ඒක අර මං ආසනේ මේ දැන් ඔළුව හෙලවෙනවා වගේ නෝ background එක දැම්මම දැක්කද?
Yeah, of
But
course.
you are not normal.
Yeah. But I will be appearing for a short period, ne?
Yeah, that is good. Very nice.
Thank you.
You would have remind us in the morning like Facebook to change our Zoom this thing.
Yeah. I have made a committee. They will do that. Don't worry.
මේ background එකත් එක්ක ෆොටෝ ටික ආවනම් ලස්සනයි. චාමරේ ඉන්නවනම් ගන්න.
All right, I'm here.
Okay, can you on your camera then?
It says you can't start your video because the host has stopped it here.
Okay, then wait, pass it.
Now all the families can on their camera.
Okay, good. Ishan will take a photo then.
Hello, Chamara.
Hello, sir.
And have a
Morning.
smile.
Morning.
Pose for the photo, Chamara. Hare Dishan. Have you done Dishan?
Yes, madam. Yes.
Amar, if you want, you can join later. That's fine. Half an hour is there. Thank you. Good morning, everyone. We welcome you all to the second pre-congress workshop of SIMCON 22, which is the pinnacle event of Sri Lanka College of Internal Medicine. This has two segments. Part 1, Future Internist, dedicated to senior registrars in internal medicine. Part 2, Navigating SR Training. This is also dedicated to all postgraduate trainees and senior registrars in any field of medicine. From last year onward, apart from the most popular How to Pass MD for registrars, we are conducting a segment of Navigating SR in our pre-congress workshops. Trainees who are with us over this year well aware about the Senior Registrar Forum, a brainchild of current President Dr. Ganaka Senaratne. Over the year, we had 8 forums and we made this particular one as an may I invite Dr. Ganaka Senaratne, President, Sri Lanka College of Internal Medicine, to address the virtual audience.
Good morning, everyone. Thank you, Dr. Premali Jayasekara. Professor Sarath Lekam, Senior Professor of Medicine, University of Runa. Dr. Chamra Dalgama, Senior Lecturer in Medicine, University of Peradeniya. Dr. Baranamilla Vitana, Specialist in Internist and Consultant Physician. And Dr. Roshan Lienege, our Honorary Joint Secretary. And Priyamali, our Honorable Treasurer. And all my senior registrars joining today. You all are very welcome for this second pre-congress workshop of SIMCON 2022. Actually, the SIMCON 2022 will be staged on 5th to 7th November at Cinnamon Grand under the theme of enhancing clinical excellence, capacity building and humane care. So it's very, very important to support our trainees, as Priyamali said, for them to become competent, confident and compassionate internist in one day. As we've been having this SR training program right throughout the year under the leadership of Priyamali, we thought it's really timely to bring it up as a pre-congress in the name of Future Internist, because you guys are about to be commissioned as an internist or as a specialist in near future. I believe so many important aspects will be discussed in these two segments, especially two segments today. Professor Lekamasam, dear sir, and Chamara, we are really honored to have you with us today, sharing your expertise with our trainees. I mean, I'm really thankful for both of you. And Priyamali, I'm really grateful for your all the efforts for passionately leading this entire program right throughout the year. Dear senior registrars, I sincerely believe this particular pre-congress will help you to become competent, confident and compassionate internist one day. And it will be a really morale booster for you attending to this pre-congress as well as the main congress on 5th to 7th at Cinnamon Grand. So without taking much time, I would wish all of you really very best for this program today. Thank you very much. Thank you, Premal.
Thank you, Ganaka. So we'll start with our first topic. It is internal medicine specialist, adversities and opportunities. So let me invite Professor Sarath Lekam, Chair Professor of Medicine, University of Rupuna, to deliver his speech. Bear with us for a second.
Hello, ladies and gentlemen. The journey of humankind has always been full of surprises, opportunities, and also limitations, adversities. It is that the mankind has always chosen the opportunities given in the middle of adversities so that humankind has progressed and come to the point that we are today. We have gone through many evolutions, like intellectual evolution, agricultural evolution, industrial, and then at last, we have come to what is called the automation. All these were possible because the humankind has to look at the challenges and then take up all the challenges on this board and minimizing the adversities. So, ladies and gentlemen, let me thank the College of Internal Medicine, Srinagar College of Internal Medicine for inviting me to give this lecture on opportunities and adversities faced by the internal medicine specialist. I thoroughly apologize for not being able to be there in person for the lecture because of the commitment somewhere else. As I said in the history of the humankind has faced many adversities and challenges, and some of them are natural, and some of them are man-made. But along the way, there are opportunities and also lost opportunities that we regret. How the humankind has come progress in this process is through adaptation, innovation, and experimenting. Some of them have gone horribly wrong, but some of them survived. So if you look at the opportunities and adversities, basically they depend on the system and the local factors. And also it depends on the individual and how you perceive issues. Would you see the particular issue as opportunity or as an adversity? It is up to you. It is up to the person to perceive it and then grab it. This is one of the very good example where a group of researchers have found adversity and then made it to opportunity. And this story goes to 1992 when we were in training. And there was a period where the paldroxine was not available in Sri Lanka. And this was the height of the war, civil war. And then for some reason, the paldroxine was not made available and the Ministry of Health could not just purchase that. But this group of researchers took this opportunity and then they compared the patients who were treated with paldroxine and also people who were treated without paldroxine and then compared their clinical outcome. Is one of the very good example. And also that the opportunities and the limitations depend on the situation. For example, when you're working outstations is really a challenge. And also once you come particularly from the overseas training and the cultural shock at the very beginning is inevitable. And then there are limited human and other resources in workplaces and also limited support from other specialties. And also where logistics like traveling and housing, the family commitment and all that make limitations. Now, further, there's a deterioration skills and particular skills which are mastered during your training and also particular overseas training, and they tend to deteriorate because you don't get opportunity to continue those. And also there are limited opportunities to update the knowledge in the process. Well, then the reaccreditation is not a mandatory requirement in Sri Lanka. Now, when you look at the opportunities and speaking to junior colleagues, we are amazed with the case mix and the volume they see. I have largely worked in teaching hospitals, but then talking to the junior colleagues, we'll find that they are confronted with a huge variety of cases, like case mix is quite wide. and also volume is very high. And also there are diseases specific to the region and the locate, like infectious diseases in certain locate, like leptospirosis. There are environmental diseases like the snakes, chronic kidney disease, ethnic variations of the disease presentations and outcomes, the eating habits of people, etc. Let me grab these opportunities. For example, have a look at the ethnic differences of the disease presentation and the disease outcome, and how people perceive their diseases, and particularly control of non-communicable diseases. The ethnic variation of these things, I don't think we have adequately studied. But these are great opportunities. I was fortunate to read this particular oration when it was submitted for the review, Professor Kiraj Suri oration, CCP 2022, done by Dr. Rohit Vitarna. And then he has done an enormous amount of work on these neglected tropical diseases in Sri Lanka. And I'm sure that he did not receive huge funding for these studies. But still, he managed to publish quite a substantial work and then put into oration. So that was really, really commendable. Now, the limitations and the opportunities one face is not something unique to Sri Lanka, and is quite universal. This particular study done in USA in 2018 and shows that 80% of the physicians were at their full capacity or they were overstretched with work. And 62% were pessimistic about their future in medicine. And nearly half described their morale as somewhat or very negative. And also, about 3/4 of people complained about the burnout. And 23 physicians were spent on non-clinical paperwork, which we don't have to do that much. And 46 were planning to change their career pathway. And also nearly 50% said that they would not recommend medicine as a career for their children. So you can see that not that they are living happily in their chosen field, and there are problems. Now, in the same study, when they did a comparison between 2020, 2012 and 2018, they found that the deterioration of many domains with regard to the functioning of the physician. And they found that there's a deterioration of the patient-physician relationship satisfaction among physicians. And also intellectual stimulation between these 6 years. The professional relationship with colleagues deteriorated. And there's also professional stature of medicine also deteriorated. But for some reason, the income of compensations increased between this time period. Now, talking about the opportunities, there are two main opportunities that one can get. One is called the research, the clinician-led research, which is unfortunately not very much happening in our country. But on the other hand, also there are what's called administrative opportunities, improving the working environment, and also expansion of the already available services. Now, what you get in return is that you can get awards. But I know your own college as well as CCP, they have this scheme to appreciate what are called the innovative work done outstations to improve services. And quite impressive work people have done. So you get the recognition in turn. But more than that, I think one would look at what's called self-satisfaction, because we have given something back to the nation, back to the people in this country. Now, the case histories and the case series are something that you can certainly look at. And no one can complain about saying that you have no enough material, because case histories, you can always generate case histories and see case series and go for publication. Now, when you look at the case reports is the most basic and perhaps the most oldest way of communication in medicine. And including me, that was the entry point in research pathway for many, many people. And we know in the history, the case reports triggered the existence or emergence of new diseases like LWs and AIDS. Case report can be an unusual event in medicine, like a clinical presentation, a complication, investigation, and response to treatment or the outcome. It could be any of those. But the rarity alone is not sufficient. and there should be a message or learning point on that case report. So most of the journal that I'm working on, and then they do not look at this rarity and say 1 in million cases or 1 or 2 million cases that use the patient. That's not enough to get the attention of the editors or reviewers of the journal. There should be a learning point. You may get a common condition with mitral stenosis, but then if it has if that particular patient behaves differently from the usual conventional mitral stenosis, there may be a learning point. Now, 3 basic questions you ask when you see what to report, how to report, and in which journal. But to report, the case must be special and have a message for reader. It may be emergence of a new condition or complication, as I said, as SARS, maybe COVID. The confusion, the diagnosis, which can lead to morbidity or mortality. For example, I have heard many stories where the patient with dengue presented with acute myocardial infarction. Mimicking acute myocardial infarction, and then that patients can have a disastrous kind of outcomes. Look at the layout of a case report. There's basically her title should indicate that it's a case report, so that when somebody read that, it's a case report that you're going to read. Introduction need to be very brief, and the case description we maintain what is called the natural order, like a history, examination, investigations, and the management. And that is written in the chronological order. History is written in chronological order as they happen. And you put in positives and important critical negatives and important positives. And then stress the point that you need to highlight. So that is the main thing. The discussion focus on the message or learning point. So whenever I get to review a case report, what I do is I look at the title and go to the discussion immediately and see that whether there's a point that you could learn from this particular case. Then only I go through case and see whether this fits in for a publication. You provide graphics and drawings, and then you need to obscure the identity of the patient for ethical reasons. But whenever you see a patient that you think there's a potential for the publication, and make sure you get a written consent from the patient that photographs will be used. So that's always worthwhile taking the consent and keeping it somewhere. And discuss on the point you need to highlight, indicating what lessons to be learned, and also then give only few references, because all the journals, they limit the references to very few. And also some of the journals have got what is called the number of authors that can be listed under case report. And I think most of the people say about maybe just 4 or less than 4 or 4. And because you can't have, let's say, 10 or 15 authors. And once we debated that in one of the journal, and I came across this particular piece of work. Somebody has written a nice article on, does it take a whole village to report a case? And because this particular author has seen a case report, it's about 20-30 people, authors are listed under. And then he commented saying that does it take a village to report a case report? So make sure that you have only about key people involved as authors. There are landmark cases, as all of you all know, when in 1981, somebody saw that extensive or disseminated sarcoma in young homosexual men, a series of cases, and then that triggered the what's called the case of AIDS at that time. Sarcoma is not something new, but again, when you get extensive disseminated sarcoma in young men, group of young men, and then somebody took a notice of that. And also the occurrence of pulmonary hypertension with these 2 drugs used for the obesity, and also there were first case reports published in Lancet. When American Medical Association reprinted 51 articles that been published in JAMA that changed the science of the clinical practice during the 150 years of the journal existence, and they found that about 5 of these papers are case reports. So case reports are not actually forgotten. I mean, they are not inferior considered in publication. They have a valuable role. In the era of evidence-based medicine that we are practicing, it's worthwhile reading this particular piece of write-up. And this is what's called case report in an evidence-based world. I think it's a worthwhile read in that. Now, this is PubMed search I did when it's a case history and Sri Lanka, and you can see that there's a fairly exponential rise of case series in the recent past. So that's a positive trend. Now, the other area that you can certainly look at is what is called the patient registries. Now, patient registry is an organized system that uses what is called the cohort or the observation research method to collect data. So it's a group of patients that you have selected and you follow them up in an organized manner and with the scientific assessment of patients' outcome. And this is an important tool in research, and many people have actually started doing that. Now, patient registries are different from what is called health information registries. For example, Sri Lankan Cancer Registry. And Sri Lankan Cancer Registry would record only the, let's say, age, gender, type of cancer, or maybe just a geographical area. But beyond that, it will not record anything else. So usually these patient registries, they record the information in a naturalistic manner. That is, the patients are taken care of by the caregiver as well as the patient together, and not by the rigid protocols. Rigid protocol is only just a outside set of observation that you make on the naturalistic patient follow-up. And the registry is designed for the specific purposes. For example, you say we are interested in what is called the patients who are discharged on acute coronary syndrome. We are interested in what is called 6 days mortality. So that is our objective. Or else we can say that the patients who present with, let's say, some type of cancer, we are interested about their quality of life, or patient satisfaction, maybe quality of life at the end of 12 months. So that is what's called a research objective. And then you have to make sure that you collect data in order to fulfill those requirements. So that is the difference between what is called a disease registry, like a cancer registry, and a patient registry. The patient registry has what are called predetermined objectives, which are scientific. And then the data collection, you must make sure that the data collection include all that information in order to answer that question. Is something that certainly is not difficult. It's something that you can do. For example, we don't know the, let's say, mortality of patients or reinfarction rate of patients who are discharged from acute coronary syndrome within, let's say, 90 days. That we don't know that information. But it's not very difficult thing to do. And because those patients will be coming to the clinic anyway. And also you collect information the uniform manner from your patients. And then it is usually you have a history examination that tests on the patient reported data. So as I said that, in the data collection, make sure that you collect data in order to fulfill for the purpose of the registry. Now, other areas of concern with regard to internal medicine. Now, internal medicine clinician has to live up with what are called multiple inputs and multiple invention and multiple drugs. Because he's in the center of, let's say, a patient coming with the diabetes, hypertension, and the chronic renal failure, pulmonary edema. And this patient is managed by, let's say, a group of people. Also, it's not a team management, it's managed by a group of people, and they are working in isolation. So it's not a situation where they all get together, sit with the physician and take decision on this patient. So what happens that, those people are taking care of their particular area or entity alone. So the clinician has to face what are called multiple inputs from various people and also suggested intervention and the drug. So all these are not coordinated. So internal medicine as a specialty, I wonder, this is my just personal opinion, becoming a lead specialty. Because when patients are, let's say, from the admission, patient with the GI bleeds are taken care by the gastro team, and the patient with acute coronary syndrome is taken by the cardiac team and the respiratory team and so on and so forth. And then the physician, the number of patients that you see as internal medicine is becoming less and less. So becoming a bit of a lean specialty. But the real danger comes when there's establishment of geriatric medicine and emergency medicine, because geriatric medicine, the Sri Lankan, the age limit to define old age is 60 years. So a potentially patient older than 60 years would go to a geriatric medicine, right in, let's say, in UK. And also emergency medicine will take care of all the emergencies, and then by the time they come to the ward, they are generally settled down. But apart from the internal medicine becoming a bit of a lean specialty, there are various other elements which are, people see all over the world. One is what's called fragmentation of patient care, where the patient care is not coordinated and is fragmented, and also leading to over-investigation and over-treatment. The case scenario, a 63-year-old woman with diabetes, hypertension, vertebral fracture, and osteoarthritis, and she was under 3 clinicians. And she had a minor fall, twisted her right ankle, and then developed tendon effusion on the next day. Admitted to the hospital, she was treated with 2 antibiotics. But of course, after about 3-4 days, there was no improvement. When I saw the patient, she was on 13 different drugs prescribed by 3 different groups, and then including 2 vitamins and NSAID. She had repeated loads of blood sugars and the lipids run over and over again. But then renal function had not been done for 5 years. She saw serum creatinine turn up to be 4.5 milligrams per liter, and also potassium found to be 5.6 millimoles per liter. What she really had was actually not septic arthritis, she had gout. And then aspiration, and then the kind of microscope confirmed that she had gout. So she settled down with hemodialysis, and with a bit of steroid, her gout settled down, and also she got better. So this is where one situation where there's a fragmentation of the care, and the patient is not taken as a bit of holistic approach to the patient. Patients are treated by bits and pieces really. So a fragmentation of patient care without a central coordination. So the internal medicine physician is the one who should be fulfilling this role, because he fits into that role very, very nicely. He should be in charge of the central coordination of the patient. And then you can avoid what's called polypharmacy. And you will be deciding whether this particular drug is good or bad for this patient. Maybe suggested by one specialist, but then you know that the patient has got limitations and patient can't take this particular drug. So you're the one who is sort of, best suited to take be in that role. So you can avoid inappropriate prescribing, inadequate monitoring, that you can certainly avoid. This is a story of another patient, which I showed in the Gall Medical Association, my lecture, as well in the frailty. 80-year-old man with a hypertension, diabetes, and mild memory loss. She's admitted to the positional vertigo. This is what looked like quite a benign positional vertigo. And admission, she goes on 180, and the blood pressure was 160 upon 85. There's no postural drop. And NCCT has been done for some reason. And then there was a question whether the patient has got normal pressure, hypertension. But then in retrospect, and patient did not have anything to suggest normal pressure, hypertension. He had a memory loss, mild memory loss, but that was not recent onset anymore. So 50 CCSF was removed, and there was no change in the condition, and then acetazolamide was started. And then antihypertensives and oral hypoglycemics were escalated, and he was discharged on 12 medication. He went home and slept whole day. And when he tried to the relatives persuade him to walk, and then he fell down. And then, of course, he did not break anything. Serum sodium was 110 when I saw, potassium 3.5, capillary blood sugar was 89, and blood pressure seated. It was 100/60. So he was suffering from what is called the polypharmacy and adverse effects of all the drugs. So medications are reduced to 6, and the acetazolamide was stopped. Antihypertensive and orgasms were adjusted so that to meet different targets, like treatment targets, like blood pressure targets and the blood sugar targets were changed. And then these drugs were modified. So he regained his normal activities after 2 weeks. So he was his usual self before he went to the hospital, and then he was okay. So this indicates that how the polypharmacy and then the irregular kind of interventions lead to what are called catastrophic clinical outcomes in patients. So in summary, the position of internal medicine is challenged from various angles, and there are many adversities. I will certainly admit that. But there are plenty of opportunities, and these opportunities should be taken, because once you lose an opportunity and might not come back. So that may be the last chance. There will be the last chance is that opportunity. The specialist in internal medicine is the central control point of complex medical problems, for which you need a wide subject knowledge, and then a holistic approach to patient needs. So that is what is really required, what is called a holistic approach. And then what you need is more than that, you need a common sense. So that's my last slide. So thank you very much for listening to me, and I really wish all the best for today's other proceedings. So thank you very much for listening to me.
Thank you very much, sir, for that thought-provoking lecture. Second lecture is Broaden Your Horizons, MRCP Specialty Certificate Examination. And you know, MRCP certificate examination is a globally recognized specialist certificate examination which offers physician a postgraduate qualification, and it is a standard practice in United Kingdom for a specialist trainees. Today, we are here with Dr. Chamara Dalugama to know what benefits we Sri Lankan trainees obtain by achieving this goal. So I found the most suitable speaker for this one, who has maximum number of specialty certificate to his credit. So may I invite Dr. Chamara Dalugama, Senior Lecturer in Medicine, University of Peradeniya, consultant physician, to deliver his speech.
Okay, very good morning to you all, and thank you very much, Dr. Biamali, for that generous introduction. And before I start, let me welcome all of you for the second pre-Congress workshop of Sri Lanka College of Internal Medicine. And for the next 30 minutes, my task is to share some thoughts and experience with regard to MRCP specialty certificate examinations. And the topic is MRCP Specialty Certificate Examinations, Broaden Your Horizons. So actually, this is meant to broaden the horizons of an internist. So before I start, let me ask this question, right? So MBBS, you all say yes. An MD in general medicine, yes. An MRCP UK, yes. But then why MRCP Specialty Certificate Examinations? Right. So what are the added advantages of doing MRCP SCE? So I'm sure you all will agree that universally recognized credentials are more important than ever in today's global healthcare market. And also, when you have the right qualification, that can certainly cross international boundaries and create new opportunities for aspiring specialist physicians or internists, right? So if I sort of go into detail and emphasize what are the advantages of having a specialty certificate examination. So these MRCP SCs are considered, as Dr. Priyamali mentioned, the gold standard postgraduate qualification for physicians in the UK. But for us Sri Lankans, it's a golden opportunity to measure our knowledge against an internationally recognized yardstick. And also, it always provides valuable currency when you're applying for a new role, either at home or abroad. So in a very personal note, when I applied for my overseas training after completion of my local training, I had my MRCP in acute medicine and MRCP specialty certificate in diabetes and endocrinology. So when I applied to Oxford University hospitals in the interview, they considered it as a very prestigious qualification, and they were very happy about that. So when you are applying for jobs, I think most of the audience are local trainees who have completed their MD. So this will be a very added advantage if you have a specialty certificate to secure a job in that discipline. And also it is considered as an international benchmark for postgraduate medical education. Right, so if I talk a bit of history about specialty certificate examination, this doesn't date back to decades and decades. It was launched in 2008, right, 14 years back, by the Federation of Royal Colleges of Physicians, London, Edinburgh, and Glasgow of the United Kingdom. Right, so since then, more and more UK trainees were asked to take this exam as a part of their specialty training. Right, okay, so then we'll see what specialties are available as specialty certificate exams. So you have acute medicine and dermatology, diabetes, endocrinology, gastroenterology, geriatric medicine, oncology. So there are nearly 11 disciplines which you can take up as a specialty certificate exam, right? And from a internist's point of view, I believe acute medicine, then diabetes and endocrinology, geriatrics, palliative medicine. So all this will be very important in your clinical practice, particularly when you're practicing abroad. These are the patients where we are going to see in acute medical take as an internist when you're managing the patient. So it is very important that if you have some extra knowledge or some more qualification on these disciplines. And also, if you ended up being a general physician, but you had some interest in neurology, or say you had some interest in respiratory medicine, yes, why not take it? So you can certainly do your neurology and or rheumatology or respiratory medicine as a specialty certificate, just to polish your knowledge and also to keep in par with your interest. Right. Okay. Then we will discuss how these exams are delivered, right? So each specialty examination is developed in partnership with the relevant medical specialist society of the UK. So if I take an example, acute medicine, yes, the RCP delivers the exam, but they do it in collaboration with the Society of Acute Medicine. So similarly, if it is geriatrics, it is in collaboration with the British Geriatric Society, right? Right. So then this is, I think, a very important slide about the global reach, right? So as you can see in the world map, the specialty certificate exams are delivered in many centers across the globe. And importantly, you all can see there is a tiny dot on this tiny, beautiful island, Sri Lanka. So basically, if you want to do the specialty certificate examination here itself, so you can do it. So why not delay? So you can start thinking of doing a specialty certificate. And then you might ask, okay, are there any eligibility criteria to sit for this exam, right? Certainly for MD Part 1, there are certain prerequisites. So you need to have, say, 1 year post-internship training, etc. But for SCE, there are no entry requirements other than having a basic medical degree, right? So you have your MBS, you need not to have your MD or MRCP to sit for this exam. But the most candidates in the UK training post, they normally take up the specialty certificate exam in their penultimate year of higher specialty training, usually in year 7 or year 8 of their specialist training. But for us, of course, there is no such entry requirement. So soon after MBBS, and you can work on that, and you can certainly sit for the specialty certificate exam. But although there are no eligibility criteria to sit for SC, that there are certain criteria set up by the RCP to use SC as a post-nominal qualification. So you need to have the full MRCP, including the PACES, and then you need to pass the MRCP specialty certificate exam, right? And then also in UK, you are expected to have a certificate of completion of training in that particular specialty, right? So you have the full MRCP and then you do the MRCP exam. At the same time, you need to have some training in that particular discipline to use it as a post-nominal qualification, right? Okay, so I will briefly talk about the exam format as well, right? Because then you will know what this exam looks like, and then you can sort of think of whether you want to take up this exam and do it. So it is a computer-based exam, and then you will have multiple choice questions, and they are divided into 2 main papers. And then for each question, you are asked to select the best answer from 5 options. And for each paper, you have 3 hours, which comprises 100 items. So altogether, you will have, for full exam, we'll have 200 questions, 100 in each paper each, and then 3 hours per paper. And in each question, I mean, basically what they ask is based on a clinical scenario with the results of some investigations and perhaps an image or a scan. And the questions test the medical knowledge and your competency, particularly when it comes to diagnosis, investigations, management, and prognosis. So that is how the exam is sort of set. And then whenever we sort of take up an exam, the first question comes to our mind is, okay, what's the curriculum? How does it look like? What really will they ask from us, right? So in that case, you can certainly refer to the MRCP UK site and look under each specialty. So they give the curriculum. So this is easily downloadable. So for each, I mean, this curriculum actually not for the specialty certificate exam per se, but this is for the whole training program, right? So for instance, here it says the specialty training curriculum for the acute internal medicine, and then for geriatric medicine and diabetes and endocrinology, right? So it is for the whole training program, but you can get a very clear idea about what is the breadth or what is the depth of knowledge and skills and diagnostics that they expect in the exam, right? And then you will see when you download this curriculum, it has so many pages, right? Maybe 60 pages, 70 pages, 100 pages. No, if the curriculum is big like that, so I'm never going to start finishing sort of studying for this exam. So you might get discouraged. But then the other good thing to look at is the exam blueprint, right? So the curriculum is for the whole training program. So it's a bit broad, but the blueprint, the exam blueprint will tell us what are the areas that will be questioned and the relative bulk of each area. So I have taken one example about diabetes and endocrinology SCE, right? So with regard to diabetes, so they ask about the diabetes diagnosis, general management, delivery of diabetic care, around 28 questions. The diabetic emergencies, another 12 questions. And complications of diabetes, another 28 questions. So nearly 60, 70 questions on diabetes. And then there are some questions on other endocrine systems like thalamus, hypothalamus, thyroid, adrenal, etc. So now you can get an idea. Okay, so in the 200 questions that I'm going to face as a SCA, these are the areas that they will ask questions. So I need to sort of give more bulk or more weightage for these areas. Right. So now, you know, what is the curriculum looks like and what is the exam blueprint? And the next question is, okay, now I want to study for the specialty certificate exam, but what resources do I have? Right. So there are ample resources that you can certainly refer to. So let me start with the simplest one. So that is the sample MCQs that is given in the MRCP site. Right. So the sample MCQs, basically, there are around 100 MCQs per each category. So you can start from there. Right. So these MCQs are in the exam style. And at the end, you can get the score. And you can review all your answers with a small explanation for each question. Say, for instance, if you take acute medicine and if you go to the acute medicine subcategory in the MRCP site, yes, you can load an exam and then that gives around 99 or 100 questions on acute medicine, exactly in the same format that is asked in the exam. So you can take it as a quiz, you can do the 100 questions and at the end you get your score. So it looks like a pre-test questionnaire for you, maybe if you want to take up, and then you can get an idea about, yes, this is where I am. And it gives a nice breakdown of your answers as well. Like about the medical emergencies, how would you were, and about geriatric, how would you were under acute medicine. And then certainly you can sort of work on that. And the other important thing is, now, if you take the acute medicine blueprint, there are certain areas where geriatric medicine will be questioned there. Palliative medicine will be questioned there. And diabetic emergencies, other endocrine emergencies will be questioned there. So you have 100 MCQs each for such disciplines as well. simply when I was preparing for my acute medicine, the first thing I did was I did the sample questions in acute medicine. And then secondly, I did some questions in palliative medicine, and then some from diabetic emergencies, and then some from geriatric. So that gives you access to nearly, say, 300, 400 questions. And then after this, you can look up in the guidelines. So most of the questions will test the knowledge based on NICE guidelines, that is National Institute for Health and Care Excellence, and also some questions on SIME, that is a network of guidelines called Scottish Intercollegiate Guidelines Network. And I'm sure by now you must be appreciating that at times the clinical practice, in our clinical practice, there are significant discrepancies between the guidelines published by various colleges and the local guidelines practiced in Sri Lanka. For example, if you take the local antibiotic policy, which is quite different from what the NICE recommends. But when it comes to this exam, your answers should be mainly based on these guidelines. And then thirdly, there are a lot of online MCQ banks. They're very good. You can subscribe one of these MCQ banks, and then they usually have around 400, 500 questions on each discipline. And then these questions again exactly in the exam format. And then they have a nice feedback at the end. And you can do it as a test. And then you can select sections like in acute medicine, say you want to do the geriatric part with regard to acute medicine. You can select that section, do it, and read the responses and then the feedback or the explanations that they have given, and to get a good knowledge on that. Right. So I have personally done the PASS test and BMG on examination, and they were very good collections of MCQs, quite similar to exam, not the same questions, but you can do it, and you can certainly subscribe or purchase these question banks for a fairly reasonable price. Say, it depends on the time, maybe for 3 months subscription, you can take it for 30 to 40 pounds, right? And also, in addition to that, if you take each discipline, under that discipline, they will recommend a specific resource list as well. So say, for instance, this is what you see for the diabetes and endocrinology. So they recommend certain textbooks, they recommend certain guidelines and journals and conferences. But then it becomes too lengthy, like there's a lot of material to refer, but you can simply start with the MCQs, guidelines, and 1 or 2 MCQ banks. And then if you have any concerns, any discrepancies, you can refer to these resources mentioned in the site, right? Okay, then we will take, so the examination dates. Usually the specialty certificate exams are held once a year. And if you are keen on doing one of the exam in coming future, you can certainly refer to the site, and then you will find when will be the exam. Say, for instance, now you are, I don't know, but you are motivated to do acute medicine. Yes, there is an exam in 2023, August 9th. So that is the exam date, and they give an application period. So you can certainly apply during this period and get selected. I'm qualified to sit for the exam, right? And then, I mean, this is again, I may be repeating the same thing, but in very simple terms, how to apply from Sri Lanka. Yes, you need to register in the site, and then you request the test country and the city. For us, of course, there are not many cities, Sri Lanka and Colombo. And then the applicable examination, you have to pay the examination fee. And then this will be coordinated by an intermediate center, basically a Pearson center, which will sort of book the seat in that test center and confirm to you 3 weeks before the exam, right? So when it comes to the examination fees, I think these days, this is going to be a bit of a problem. But if you are an international candidate, if you are sitting for the exam from Sri Lanka, so I think I've taken this maybe a couple of days back, things might change, but it's 833 pounds. And for UK candidates, it's around 665 pounds. And one other thing is, if you go and work in the NHS under a trust, sometimes your trust might fund you for this exam. So I did my MRCP geriatrics when I was in UK, and then I was having some geriatric training by that time. So after explaining that this exam will help to practice there, the trust funded me for the exam, as well as they funded the course fees, for this online course materials and even the bus fare, right? So if you find it difficult with the current things to do it as an international candidate, certainly when you go for your overseas training, discuss with your trust. And if you are doing acute medicine, the trust will be very happy for you to have the specialty certificate in acute medicine. So there are certain trusts that will fund you, so you can do free of charge. Right. Okay. So then, again, talking very briefly about the exam delivery and format. Yes, as we discussed, it's a computer terminal at the invigilated Pearson Center. And before test starts, you don't have to worry because you can complete a brief tutorial on the screen to ensure how to record your answers and scroll through the questions, right? So again, this is exactly what you get in the Pearson mock test. So they ask what is the color of the sky. So you are given the picture, you are given the answer. So you need to answer. And if you have, this is a very self-explanatory, so I will not waste time on this. So this is the exam test setting, right? Okay, and then once you do the exam, 4 weeks after the exam, you will get the results. And by week 8, you will get a very nice certificate signed by all 3 colleges. Say, for instance, MRCP specialty certificate on endocrinology and diabetes, or acute medicine, or geriatrics. Right, so that brings to the end of my brief presentation, but there's one important thing that I want to tell with regard to our college. Right, so Sri Lanka College of Internal Medicine, with the president, Dr. Ganaka Senaratne, and the council, one of their main aim is to arm the internist into a very powerful person, right? So the specialty certificate exams will certainly will give that, right? So we have a mentor group, and it is the brainchild of Dr. Ganaka Senaratne, and Dr. Jagat Pushpakumar is very passionately leading this group. So we had several sessions on peer learning, right? So it's basically a colleagues talking with the rest of the colleagues, discussing what was their experience in doing acute medicine and what questions asked, and they do few MCQ. So that's a very good start to motivate the internists. So I think on behalf of the college, I welcome all of you to join this group. And so either as a mentor or as a mentee, and certainly to go ahead and do the specialty certificate examinations, not just for a post-nominal qualification, but as it is an international benchmark for your medical education, and certainly it will be a valuable currency when you're applying for a job or a new role abroad. Right, so that brings to the end of my presentation, and thank you very much for your listening.
Thank you, Chamara. Thank you, Chamara, for very interesting, informative lecture. I think we will unmute all the participants now, and they can ask questions. There are 2 questions at chat box. Until then, you can answer. You can answer that question.
Right. All right, okay. Yes, so there's one question on, you always have to do the training after SC. Not for the qualification, not for the exam, but to use it as a post-nominal qualification. That is what the RCP recommends, right? So if you have done your acute medicine specialty certificate, you have the full MRCP, and then you have an acute medicine training, because we can't, as international trainees, we can't get this CCT that the UK trainees get. But we do get ourselves trained, maybe in ST6, ST7 position there. So, so that is possible, but for a UK trainee to use it as a post-nominal, they need the full MRCP, the MRCP specialty certificate exam, as well as the certificate of completion of training, right? And yes, I think the second question I answered that as well. So how can we join the mentor program? I think Sachin, yeah. So actually, I have contributed as for a session, but Dr. Jagat is leading.
Jagat is here. He can answer. Jagat, can you answer that question? Sorry, the noisy sound coming, Jagat.
Hello, can you hear me now? Is it clear or is it
Yeah.
still?
Yes, yes.
Sorry, can you repeat the question? Because I was just doing some other thing on my
So they were
computer while
asking
listening.
how to join the mentor group of SLC.
All right. Okay.
It's a
So
mentor group.
yeah, I mean, there is a WhatsApp group that the college have created. So and there will be mainly the mentors or the doctors who are conducting the program in the group. So if anyone is interested, either college or I mean they can contact me or college so that we can provide the link for the relevant MCQ program. So then you can join. It is normally like 9 p.m. to 10 p.m. like 1 hour session. So if anybody is interested, please contact me or the college, and we will guide you how to join and how to get the maximum benefit from the session.
Yeah. And Jagat, I will add that they can go to the SLC website, and we have SLC app. So it is there, and we will ask you to kindly paste your contact number or something so they can contact you. And
Right, yeah.
While Chamara is answering, I have another thing that he didn't mention as yet to come. We have past test series of SLSIM. There are the short case, Viva, picture test, and those are also aimed for the MRCP. So that is also you can get the benefit once our pinnacle event happen in coming 5th. So those books will be there you to use. So Chamar, you can answer the questions, and participant, we have unmuted all. You can actually directly ask questions.
Yes, right. And the other question is, what is the significance of MRCP UK, London and Edinburgh? Of course, once you do the MRCP exam, then you can be a member of one of these colleges, London, Edinburgh, Glasgow, 1 or 2 or even 3 colleges. And then certainly once you become a collegiate member of each college, you have a lot of membership benefits where you can have access to CPD diary, and then their online library, and then various CME programs are conducted by each college. So you will have access to that. And also, I think if you are planning to apply for a fellowship, then having a membership of each college will be important, because in the standard way, unless you have been nominated by a sponsor, in the standard way, you need to be a member for a certain number of years to qualify yourself to apply for a fellowship. Right. And then this question, of course, I have no clear idea. If we do MRCP, are we exempt from AMC in Australia? I'm not very conversant with that.
So I think even though we don't know Chamara, Australia, they don't, MRCP is not a recognized qualification in Australia. It's a different certificate. So it won't apply for the Australia. But what you can do is if there are medical officers listening to this, if you do the MRCP, acute medicine, or sometimes there are MRCP emergency medicine, there are certain things, shortcuts, apart from doing PLAB, because there's a long queue for the PLAB. So if you do that, you can get the GMC registration, but not for the Australia.
Yeah. And then I think the last question, is it mandatory to complete a full MRCP to sit for SC? No. So you don't have to complete the full MRCP with patients to sit for SC. The only eligibility criteria is to have a basic medical degree, and you can certainly sit for this exam.
I think we have unmuted all, they can ask questions. So there are some in Q&A, Chamara.
Yes. Okay.
Same thing, huh?
Yeah.
So in the absence of questions, I would like to thank Chamara. That was very informative. Do you want to ask questions, Ashini?
Yes, sorry, but I just want to ask, sir. So I'm not currently in the MD program, and but I'm midway through my MRCP, and I'm just wondering if, I mean, but I have experience in the ICU. I'm just wondering whether if it's possible for non-MD trainees to also do the SCE, or it would. I mean, is it generally advisable?
Certainly,
or
yes.
is
If
it-
you do, if you're halfway through MRCP, I mean, certainly
Yeah.
you can go specialty certificate examination. But I mean, if you're planning to get the GMC registration, you need to have full MRCP because
Yes.
that is required. And then with that, if you have the specialty certificate on top of that, so that will be an added advantage in securing a job. So
Okay.
that, yeah, that will be a very good thing.
Yeah,
yeah.
my worry was actually, sir, in the sense, in terms of training and knowledge, whether just the study base is enough, or whether like formal training is necessary in order to complete the SEs.
Actually, the best thing I would suggest is that you take up that sample MCQ quiz, which has
Right.
100 questions, and then see where you place yourself, because
Got
it is basically it's based on the clinical practice. Basically, you are given a lot of scenarios, images, and ask what is the test management option, or what would you do next. So such questions. So if you have a clinical training in an acute medical setting, that will be certainly help.
Yeah.
But it's not a must.
Okay. Right. So thank you.
Yeah, you're welcome.
Anupa, do you want to ask question?
Right.
Yeah, if anyone wants, you can ask questions. I think Isuru is answering that question they asked about this. Isuru, if you are in the panelist list, you can just give an answer. Just speak up, then they can hear other reading that.
Hello, can you guys hear me?
Yeah.
Yeah.
Hi, Chamar. So just wanted to add about MRCP in Australia. So it's not formally recognized as a qualification over there. But however, like if you are in an interview with someone, like say, for example, you have MRCP and you are competing with someone who doesn't have MRCP, and otherwise your qualifications are the same, you might have a bit of an upper hand in terms of the interview itself. But otherwise, there is no formal recognition for either pathway in terms of general medicine. Thank you.
All right. Thank you, Isuru.
I just want to ask a question. Yeah.
Yes.
Can you hear me? Yeah. I just want to know, when completion of the MD Part 2, is there exemption of MRCP Part 1?
I think currently it is not the case, isn't it, Dr. Priyamali?
So can I ask the question again?
I'm Piomi, SR Medicine.
Yeah.
I just want to know, madam, after completing MD Part 2, is there exemption from MRCP Part 1?
No, it was there earlier. Now it is no longer there. You have to do the part 1 and part 2 both. Yes.
Okay, thank you, ma'am.
Because we have 30 minutes for the next session. If you have any questions, you all can ask. And so in the absence of questions, we will wind up the first segment of this. And just to let you know before that, this mentoring group for acute medicine is for members. So if the senior registrars in internal medicine can become associate members, and all the other physician, specialist physicians in internal medicine can become members of SL, Sri Lanka College of Internal Medicine. So you all can join the mentor group for that. And so you can have tea and relax yourself. We'll be starting by 12 o'clock, or you can, so be with us. We will back in 12 noon. Thank you. So if there are panelists like Dr. Chandimani, Barana, they can just see whether your presentations are working and all. Chandiman, you can check your slides and just see whether the video is working or not. So if you want to check your slides, you can check. Dishan, can we have that navigating SR screen?
I'm calling you a webinar lecture conference. I'm calling about the Oscar. Yeah, I'm okay. I'm fine. I'm fine. Let's start it. Okay, see you. Bye.
Yeah. Hello.
Lights and all, we will be starting at 12 o'clock. But as it's a virtual platform, I want to get a photo of all the speakers. I just asked Chamar to join. Once Chamar joins, if everyone of you on your camera, the Dishan can get a nice group photo of us.
I'm sorry, I cannot open my camera, by the way.
So we'll let you, 1 second, we'll allow you to open on your camera.
Thank you. Thank you.
I think I can't start my video again.
Yeah, Dishan shall be on.
I think
Alright.
I get a message saying that the host has stopped it. So I
Yes,
think
we'll let host to do it. Chamar, okay, Jagat is there. Nishan, Lalit Vijayaratna sir's camera also not given the permission.
Can you hear me, Priyamali?
Yes, sir.
Can you hear me clearly? Right,
Yes,
thank
sir.
you.
Chandimani, can you on your camera, Bharana?
Priyamali, they are not letting us on it.
So yeah, it's one by one. So it's appearing.
Now it's open. My
Yes,
camera
sir.
was.
Can see you, sir. Nice to see you, sir. Isuru, Keshani, Bharana, can you on your cameras? Dishan, can you instruct us how to stay, like rather than one picture here? Now we can see the sir, like you know, the 8 class or something. Dishan?
Yes, madam. Yeah, that's also can now. All the sirs
Yeah.
now can.
Yeah, all are here. Keshani is not here. Isuru, can you on your mic, camera?
I'm here, madam.
Yeah, it's on.
Ah,
Yeah.
okay. So we'll on all our cameras.
Just have a,
Director?
just focused on the camera, madam.
Okay.
Yeah.
So say cheese.
Just give me a minute, madam.
So Ganaka can't see Ganaka.
Am I seen, Primali? Am I seen?
I think Rishan can see. I can only
Yeah.
see few people.
Yeah, can see, can see.
Yeah, I can see you.
Okay, sir.
Okay. Can you take it now?
Yes, madam. I'm going to take it.
Okay, thank you. Varana is there. Varana? Varana, are you there?
Yes, yes, madam.
Ah, okay, that's it. Yeah.
Have you done, Dishan?
Yes, sir.
All right.
It's done? Okay, thank
Yes,
you.
ma'am.
Thank you.
Thank you.
Hello, sir.
Hello,
Hi,
hello,
sir.
Ganaka. Hello, yes.
Good afternoon, sir.
Good afternoon.
Okay.
Very nice
Thanks
to
for
see you.
inviting us. Me too.
Hello, Chandimani.
Hello,
How are you,
Ganaka.
madam?
Good,
Very
good.
nice to see you.
Yes, likewise.
And
Really happy to
Barana.
see the program going well, Ganaka. Congratulations. Huh?
Oh, yeah. We have a fantastic team. Priyamali, Jagat, Roshan. So
Yeah.
like our council those days, very
Yeah.
beautiful people.
I'm so happy and proud to see you doing
20,
all
15
these, Ganaka.
days.
Excellent. Excellent. I'm so
Ganaka,
proud to see
I'm going to start now 12 o'clock.
All right. Okay.
Yeah. Okay. Good afternoon, everyone. So we are back in Navigating SR. It's a segment 2 of Senior Registrar Precongress. Let me welcome, ask Dr. Ganaka Senaratna to address you all before starting the second segment. Ganaka, over to you.
Thank you, Priyamali. Very good afternoon for all of you. Dr. Lalit Ratna, dear sir, a senior consultant rheumatologist. Dr. Chandimani, consultant respiratory physician, my dear friend, and Dr. Baranamil Vitana, specialist in internists, my dear friend, and Dr. Keshani, Isuru, Jagat, all specialist in internal medicine, and Priyamali, our dear treasurer of the college, and Roshan, the secretary of the college. And my dear senior registrars, you're very welcome for this second segment of the Pre-Congress number 2 of SIMCON. As you all know, SIMCON 22 will be staged on 5th to 7th November under the theme of enhancing clinical excellence, capacity building, and humane care. So I believe this particular workshop would help all of you to achieve this most important parts in your career. In a personal note, I'm really, it's a very heart-touching occasion for me, as I was one of the most junior council members of Dr. Ratna's council those days, I think 2014 or 15, when he was the president at CCP, and who pioneered the process of bringing MRCP places to Sri Lanka. And then always Chandimani and Barana being the pillars of that process, even then and now, I believe. And it's so wonderful to have you, Sir Chandimani and Barana, in this particular forum. I'm really honored and humbled, and to have all of you, Sir, Chandimani, Barana, and all the other speakers joining with us here today, Suru, Keshani, Roshan, and Jagat, for this particular segment. I believe this segment would help our senior registrars to become competent, confident, and compassionate specialists in one day. And I must thank all of you for joining, and sincere gratitude to Priyamali for passionately leading this project. and wishing you all the very best for this particular segment. Over to you, Priyamali. Thank you very much.
Thank you, Ganaka. So we will be starting a topic of an aid to the MRCP patients. So the MRCP Part 2 clinical examination is a practical test which we call PACES, which will assess the clinical knowledge of a trainee and the skills. And actually you must have to pass your Part 1 MRCP within 7 years before you sit for your PACES. In coming back to Sri Lanka as MRCP PACES Center, Kanaka has mentioned a bit, back in 2015, then President of Ceylon College of Physicians, Dr. Lalit Vijayratna, Secretary Dr. Chandimani, and then that time CCP got the invitation from the RCP, then Dr. Barna Millavithana, who had experience in organizing MRCP PACES in UK, with dedicated team of CCP members, started mock examination at 2016, and they accredited, or they started our center, recognized our center. So we'll let them tell our story and top tips for passing MRCP PACES. May I, it's Dr. Lalit Vijayratna, Host Examiner Sri Lanka, Consultant Rheumatologist, Dr. Barana Millavithana, Convener MRCP PACES Committee CCP, Consultant Physician, and Dr. Chandimani Udugalige, Consultant Pulmonologist, MRCP PACES Examiner, currently working in UK, will be joining the panel. Over to you, three of you.
Thank you.
Recording in progress.
Bit of a noise, I don't know from.
Yes,
Okay,
can
that's
I-
fine.
how can
Now
I-
it's done.
How can I?
So if
open
you
my
have
presentation?
open 2 devices, there will be sounds. You have to unmute one device.
Shall I come again?
So you can just share the screen if you.
Share screen, I am pressing that. Advanced issue. Yes, when I press that, I get this. How can I get my presentation, please?
So when you share the screen, there will be a few windows appearing in your computer. Are you using a Mac, sir?
Yes, I'm using a Mac, yes.
So there will be few windows appearing. So you just need to click your you open your presentation.
I have opened it already. I have already opened that. 1 minute, please.
Ishan, maybe that sir may have to go to this system and.
It's not in the advanced one, sir. It's probably in the basic. That screen when you open, there's a basic, advanced. So basic one, you can see your screen, sir.
Sorry. When I open it, I get entire screen, window, and Chrome tab. How can I? Sorry about this.
Excuse me, sir. Just put the share screen, sir.
Yeah.
Then you will be getting then you will be getting a kind of a window. There is a basic, as Dr. Barna correctly mentioned, there is a basic kind of a share screening option. Just that's the first one, sir. You just need to click that. And
Yes.
enter the bottom of the left right-hand side corner. There is a share button, blue color one.
Okay.
Just enter
Which
that.
I
Sir.
did. Which I did.
Yeah.
And then I get this. Then how to go from there onwards?
Then it is automatically sharing. Sir.
Can I? It's the window I have got to share. Sorry about this. I can see Chandimal here.
So when you open, do you get, what does it, when you press share screen, what do you get,
I
sir?
can see you. I can see you. There's called an entire screen, and you are there.
Oh, no. You must have clicked on our Zoom link. So that will also come, sir. So on one, so desktop one or whatever the desktop, you would see that. But then you should see the other windows, other files or documents that you have opened on the desktop.
Right.
So right on top, can you see there are three things which says basic, advanced, and files.
No, I don't get that, Chandimani.
So is it the latest Mac, sir?
Yeah, it's the latest one. Yeah.
Occasionally, can you instruct, sir, the other, like the other day, what happened to the Megan? Maybe the same thing.
So I'm Keshini here, sir. So when you did you, like, from the system preferences, have you already given permission for your Mac to access the screen, sir? So if not, you might.
I think I have done that.
Right. In that case, sir, when you click on share screen, like Dr. Chandimani mentioned, you should get the different desktop screens.
They say one panelist can share at a time, multiple panelists can share, and advanced sharing option. That's all I get in this.
I'm not sure I know how to proceed.
Sir, do you want, if you send me your slides, I can show them from here if you like.
Shall I email them? Shall I email them to you?
Please email this to.
I will share slides.
Okay,
Right.
and just
Then
email.
Barna can start still. Then Barna can start, isn't it?
So they want to start with your slides, so just email it to us. So Dishan or the same where you
Shall I
get the.
send it to Chandimani?
Okay, sir. I think it's better if you can share it with the Dishan. I will just.
Oh yeah, can you send me his
I'll.
email address?
Dishan, can you just put the email address to sir?
Sir, this is Isuru here. Just wanted to double check. Did you press the green button with the black arrow or just the yellow, the green arrow itself?
I pressed the green button with the black, the green button I pressed.
The one with the green square with a black arrow?
Yes.
Okay, and what happens when you do that?
That I don't, it doesn't go to the, it doesn't open the PowerPoint.
I just send you the email address, Dishan's email address, so he can share it.
Can you text it to me?
Yeah, I just
All right, okay.
WhatsApp this SR navigating.
Okay. I have sent the slides.
Okay, sir.
I have not yet received, so we'll wait.
I sent to Chandimania as well. Chandimania and Dishan.
Yes.
Still haven't got it, sir. I think it will come.
Same here, madam.
So it has not arrived yet. Maybe sometimes the large files might not reach. May have to send us in a Google Drive.
Yeah.
So, Chandimani, until it appears, shall we start then?
I think you better start.
Yeah, and then because it's 15 minutes gone. Still, Dishan didn't receive the email, sir. In your end, it is sent, came as sent?
Yes.
So, sir, you have sent few slides to Chandimani and me yesterday.
Changed some of the slides.
Yeah. Can Chandimani will use same slides? So
I can show those slides.
Yeah, so you can you can share those
Can
slides.
we wait till I changed some of them, Barana. If you can, have you got it now? Have you got my slides?
No, sir.
No, sir.
I think just check to see whether it's there in. Ah, yes, I got it. Yeah, I got it.
Okay, thanks.
Okay, thank you. Can I start?
Yes, sir.
Yes, sir.
Well, good afternoon. First and foremost, big apology from me for the delay in starting my presentation due to the technical problems. As you know, I'm not a very expert on these computers, so I'm sorry for the delay. Well, today, first and foremost, I will thank my dear friend, Dr. Ganaka and Dr. Priyamali for the kind words introduction, and also to thank the Sri Lanka College of Internal Medicine, the president and the council for inviting me as a speaker for the Precongress workshop for senior registrar. And today I'll be talking to you on the introduction of MRC. I'll give you an introduction about the MRCP PACES exam. Next slide, please. The MRC PACES exam, as the name implies, is an exam to assess your day-to-day competence with your patients And this exam also will test your ability to carry out a proper clinical examination, and it also will assess as to how competent you are in making a clinical assessment. Next slide, please. As you know, the PACES examination is conducted in Colombo by the Federation of Royal Colleges of Physicians in the UK in partnership with the Ceylon College of Physicians. And I would like to take this moment for a minute to thank all the past presidents, present president, and all my dear friends who have worked extremely hard to get Colombo recognized as a recognized international center for the PACES examination. And I would also like to thank all my colleagues who have been working very hard, tirelessly as a team to organize this exam over the past few years. And it's a very difficult task to maintain standards. And I'm so lucky to have a very dedicated, committed team who has been working very hard to conduct this exam in a successful manner. Can I go to the next slide, please? So the International Center in Colombo conducts 2 exams for a year, and each exam is run for a duration of 3 days. And we are able to examine 45 candidates per examination. Next slide, please. I will now take you through the sequence of events during the next few minutes, just to tell you as to what happens during the exam. As you are well aware, you are requested to come to the examination center 1 hour before the exam starts. And once you come to the waiting room, I, as the host examiner, will be welcoming you. And each of you will be invited to sign the attendance sheet. And there your identity will be sort of checked with your passport and your admission sheet. And thereafter, each of you will be handed over 16 mark sheets. Next, please. And within this hour, you have to write your name and also indicate your examination number, which is the index number and the center number in each of the 16 sheets. Please remember that when you are entering the 2 numbers, you not only write the numbers in figures in the horizontal square boxes, but you also must make sure that you color the 11 cages, which sort of corresponds with your required indicated numbers. Next slide, please. 15 to 20 minutes before the exam commences, the chair examiner or the chief examiner will come to the waiting room and address you. And there he will brief you about the PACES, as to how the exam is conducted. And he will also take a few questions if you have any concerns about the PACES exam. Next. Once everyone is ready, one of the local examiners will come down and invite you and take you to the exam floor. Fine. And there the exam will commence. Next slide, please. As you know, the PACES examination is divided into 5 stations. The way the stations are arranged are called as the PACES carousel, because all what you do during the exam is to move from one station to the other, and you have to sort of move through all 5 stations to say that you have completed the exam. Next slide, please. And each, if you look at the 5 centers, station 1, station 3, and station 5 are called as a clinical examination centers, because there you will be examining patients. In station 1, you will be requested to examine the respiratory system and the abdomen. Station 3, cardiovascular system and the nerve system. And in station 5, there are 2 separate brief clinical consultations. Station 2 and station 4 are called as talking stations, where in station 2 you will be assessed on your ability on good history taking, and station 4 will be on communication skills and ethics. Next slide, please. Yes, if you look at the timing, each station you spend 20 minutes, and in between stations, next slide, please, there is a 5-minute interval before you enter each and every station. Therefore, the whole exam takes a total duration of 125 minutes, which is 2 hours and 5 minutes. Next slide, please. If you look at the timing again, station 1, station 3, and station 5 are divided into 10-minute clinical encounters. There are, because as you need to sort of complete 2 components, whereas station 2 and station 4 will stand alone as a 20-minute station. Next slide, please. Please remember that if you look at the 5 interval stations or the 5 interval slots where you have to sit and wait before you enter the respective station, the slots before station 2, station 4, and station 5 are extremely important, because in these 3 interval slots, there will be information for candidates. And here, the candidates will receive information given as an outline of the case scenarios you will encounter in the station you are about to enter. So please read these instructions very carefully, as they will be very useful for you to gather your thoughts, to organize yourself when you are taking the history, and also it will also help you to formulate your own differential diagnosis on the case scenario you are going to encounter in a moment. Next slide, please. I don't want to go into much detail because our third speaker, Dr. Chandiman Undugodage, will give you great detail on what exactly happens in each of the 5 stations. Next slide, please. This is an exam, and you are assessed on various domains. In the PACES exam, next slide, please, you are mainly assessed under 7 skills, or what we call as 7 clinical domains. Your approach to the patient, your examination techniques, and also the coherence, or how confident are you to present your clinical findings and draw your conclusions, along with how compassionate you are to our patients. All these will matter, or all these will be taken into considerations when the examiners are marking you under the given 7 skills. Next slide, please. I not want to go into much detail, because my second speaker who will be following me will be talking to you in great detail on how the marking is done under these 7 main domains. Next slide, please. Therefore, I'd like to conclude that, as I feel, MRCP PACE examination is a very well structured exam. All the patients have got very good, easy to detect physical signs. There's nothing hidden there. Everything is very obvious. And I always feel that if you formulate your thoughts and if you're quite relaxed, it's a very easy exam to pass. In conclusion, let me wish you good luck. Thank you very much, and a big sorry once again for my delay. I will now invite Dr. Marna Vitan, who is another senior examiner, to talk to you about the clinical examiner skills and how the marks are given. Over to you, Marna.
I think all of you can hear me.
Yes, we can hear you.
Okay.
We can.
So, yeah, first of all, I would like to acknowledge the CCP for starting these as an initiative PACES in Sri Lanka, and MRCP allowing us to host exam in Sri Lanka. And big thank to Ganaka, my good friend, the President Internal Medicine, as well as the Dr. Priyamali, who is the moderator of this session, for the opportunity given us to deliver this speech on MRCP PACES, how to pass. So during next 20 minutes or so, I'm going to talk about little bit, I'm going beyond the examination skills, because I'm going to tell you the basis of this examination, what are the basic things they look in this exam, and duties and expectation of a good doctor, and what patients expect from us, and the domains of good medical practice, and how clinical skills are assessed in this exam, and tips to pass with the higher score. So PACES is a summative assessment designed to test clinical knowledge of and skills of the training doctors. To pass the exam, definitely we have to understand the exam format. That is essential. And we have to think about the objectives of this exam. So exams, basically we know, are a form of learning activity. And especially PACES exam, it checked our professionalism in action. So we have to develop and maintain our professional performance to pass the exam as well as do the better service to our patient. So key to success in this PACES exam is if you practice those clinical examination skills in your day-to-day practice, it will be very easy exam, because most of you know the people who go overseas training and after returning or while in the overseas training, when they do PACES exam, they do better because they know that these things are practiced while they are doing overseas training in UK. So foundation of the assessment of PACES is based on good medical practice guidelines. What is good medical practice guideline? So in 2013, GMC issued these two documents. So one thing is good medical practice. This is for doctors. What are the things expect us as doctors? And another one, the next one, what they have given is what patients expect from us. So they tell the patients, you have to know, these are the things you should know and you should expect from your doctors. So these four domains, basically, I have taken from this good medical practice guideline from GMC, and I will go through these things because these are very important things we have to know and we have to practice, which will be help us to do this exam very easily. So a good doctor, and there are four domains. So first is knowledge, skills, and performance. So we have to provide good patient care, and we have to think about the patients as our first concern. We have to provide good standard of practice and care. That means we have to upgrade our knowledge, skills, and we have to keep them up to date. And next is, though we are very good, excellent doctor with medals, if we are not a safe doctor, and if we are not maintaining the trust with the patient, we won't be good doctors. And we have to think about the safety and quality of patient care. We have to take prompt action to considering patient safety, dignity, and comfort. And we have to protect and promote of the health of the patient and public. We have to maintain the trust of our patients. So we have to be honest, open, and we have to keep integrity. Never discriminate patients and never abuse patients' trust, and prepare to explain actions by us, actions or decisions by us, or even our team. So even our team has done something, and when we are going to talk to the relatives, we have to take this as a team responsibility. And the most important, the fourth domain is communication, partnership, and teamwork. So treat patients as an individual and respect their dignity. So treat patients politely, considerably, and respect their right to confidentiality. So these things are very important, which we have to practice and work in partnership with patients. I know most of our approach sometimes is more paternalistic. We make the decisions for our patients. But what we have to do, we have to listen and respond to their patients' concerns, preferences, ideas, concerns, and give patients the information that they want, as well as respect their right to reach decisions with our help and with our treatment plans, supports patients in the care, serve the patient's interest. So the PACES exam, basically they use these 4 domains of a good medical practice to make the foundation for their assessment method. So next, I will go through about the exam, how good medical practice guidelines translated into PACES exam to assess as a summative assessment how good you are as a doctor. So as Sir mentioned previously, there are 7 core skills. So physical examination, identifying physical signs, clinical communication skills, differential diagnosis, clinical judgment, maintaining patient concerns, and maintaining patient welfare. Now I will go through one by one. So skill A is physical examination. So physical examination, I know from the 3rd year onwards, we are taught and we are practicing the physical examination. In the exam, what we see, whether you demonstrate correct, thorough, systematic, fluent examination, which is the sequence of the examination in a professional manner. I know in the exam, it's a very stressful situation. A lot of people who are even thorough with the exam, with the stress, they do various things. So most important thing, practice physical examination and do it in the systematic, fluent manner as well as professional manner. So the physical examination skills assessed in station 1 and 3, those are basically clinical examination stations, and it will be assessed in station 5 also. Chandimani will discuss it further, but what I have to tell you, it is like a focus examination in this station 5. Skills A is testing clinical examination only, and even your physical signs are correct or wrong. If you have done your examination properly, you will get the full marks. Skill B is identifying the physical signs. So when you examine the patient, you have to identify the physical sign, either cardiovascular, abdomen, or respiratory. Just examine the patient, and the physical signs you identify from the patient, you have to tell the examiner. The negative aspect of this is, what we have seen is a lot of people create physical signs. Patient may having splenomegaly only, you may tell hepatosplenomegaly. If there's no hepatomegaly, you will be marked down. So don't create physical signs. Then clinical communications skills. So this is skill C. When our clinical encounter starts, what we do is, first thing is we'll gather information from the patient. So that is the clinic history tracking. So elicit a clinical history relevant to the patient's complaint. That is the most important. So what we have seen is people take history in very, very haphazard manner. So greet the patient, accept the patient, and you start the patient's complaint, presenting complaint, then systemic review. What we have seen as examiners, people come with a checklist where history of presenting complaint, allergy history, all these past histories, family history, all written in this paper. And what they try to do is just a fill in the blank thing. That should not be done. What you have to do is get the patient's complaint, assess, because you are now senior trainees. So assess the complaint in systematic, thorough, and fluent professional manner. And when it comes to other way around in the station 4, so we have given the scenario. So we have given the clinical information. What you have to do is you have to, with the dialogue with the patient, you have to tell accurate, clear, structured, comprehensive manner, as well as professionally, what are the information you have. So in clinical communication, it's a two-way process, information gathering and information giving. So there, what we assess, one thing is we assess the content, what you are going to get, what you are going to tell the patient, as well as the process, how well you are doing this, how systematic, how thorough, how fluent, and how professional you are. But when it comes to station 5, it is a focused encounter. So you are taking the history in very focused manner with related to the symptom of the patient. I just elaborate the skill A and C in the station 5 because Chandibani will do it in detail. So when it comes to station 5, the focus communication and focus examination. For example, I have given a patient coming with TIA, which is one of the common scenario we give in the station 5. And the patient, what you have to do is assess the symptom patient presents. And if there's any relevant things in the past history, whether you had similar sort of in the past, whether your family history has any vascular, the risk factors, or whether what are the risk factors you are having. So in the focus manner. So in this station 5, no need to do full history. While you are talking to the patient, you can even examine. If a patient coming with TIA or amaurosis fugax, what I have seen, even the TIA with limb weakness, which is history says it's recovered fully, people try to do neurological examination fully. Just keep both hands or just check the vision and see whether there is any neurological signs. But the most important thing in like TIA, check the pulse rhythm, murmurs, carotid. So your focus examination should be directed to see the important aspects of each and every system, which is you have to prioritize. So you have to practice and see. So the next thing, like the dysphagia, patients coming with dysphagia, sometimes people, when we give a patient like systemic sclerosis who's coming with dysphagia, when you come into the room, it's a spot diagnosis of systemic sclerosis. People think about the spot diagnosis, but they forget to get more details of dysphagia. So the focus history related to dysphagia, as well as the features, the other associated features of systemic sclerosis, you should ask from the patient in focused manner. The examination should be also focused manner. So station 5 is the most important station where all 7 skills assess. We have to practice how we are going to assess these things in focused manner. Right, coming back to skills, skill D is differential diagnosis. Now I have already mentioned skill A, physical examination, skill B, physical science, skill C, clinical, the communication, skill D is differential diagnosis. So either after taking the history or after examining the patient, you have to form your differential diagnosis according to the history elicited or according to the physical signs you elicited from your patient, not to a patient in your mind. Skill E, the most important thing. This is our clinical judgment. So what we do day-to-day practice, we talk to the patient, we take the history of the patient, we examine the patient, then we use our knowledge and our experience, and we give a clinical judgment. So clinical judgment is a very important aspect where trainees has to develop. So what are the meaning of, what is the meaning of this? So clinical judgment is you understand the physical signs, why this patient is pale and having hepatosplenomegaly. So you have to explain it, and you can formulate the differential diagnosis and select the appropriate investigations, treatment plan for the patient you assess. Not only that, your clinical judgment, sometimes you have to select and negotiate sensible management plan to your patient or the patient's relative. So what you are telling, according to my judgment, this is the thing this patient is having. This is the plan I'm going to give. And not only that, your clinical knowledge is also assessed. The particular clinical problem, as well as if it is like communication and ethics, how you are going to apply the knowledge on law or ethics to a particular scenario. That is skill E. Skill F, this is again a form of communication. So managing patients' concerns. You ask, seek, detect, address patients' relatives' concerns, as well as you explain and you check whether the understanding of the patient, and what you have to do is you have to do this in empathetic, professional manner. Skill G, the last skill, maintaining patient welfare. So the important thing, how we treat a patient or relative respectfully, sensitive manner, and ensure comfort, safety, dignity. In this part, most of the people score, but we don't want to see the physical or verbal roughness. Sometimes people are causing emotional and physical discomfort to the patient. That is a physical roughness. But sometimes some people, the management plan given to the patient is very, very dangerous. So in that instance, one thing, you fail in your clinical judgment because your clinical judgment is wrong. And if that your judgment causes a serious harm to the patient, again, examiners sometimes mark down in the clinical, the managing patient welfare skill G also. Okay, so I have mentioned all 7 skills, and different number of and combinations of skills are assessed in different stations. And those skills are marked in 3-point marking scale called unsatisfactory, borderline, and satisfactory. And good thing is no overall judgment given in this. So these are mark sheets. So you can see some mark sheets like 4 skills. Station 5, all 7 skills, and satisfactory, borderline, and unsatisfactory graded. So skills assessed in clinical stations. So station 1 and 3, RS abdo CVS neuro, physical examination, physical signs, differential diagnosis, clinical judgment, and maintaining welfare. So 5 domains assessed. And there is something called link marking. If in station 1 and 3, if your physical signs B is wrong, then your differential diagnosis is also wrong, and you will mention the plan also for what you said. For example, the patient is having splenomegaly, but you said patient is having the polycystic kidneys. Then your B is wrong, and your differential diagnosis, because you found the large kidney, and your differential diagnosis is polycystic, and you are giving the plan for polycystic. So the patient is having splenomegaly. So B, D, E, all 3 you will get unsatisfactory, because that is a form of the link marking in this station 1 and 3. When we talk about history taking and clinical communication, so it's clinical communication, your clinical judgment, maintaining patients' welfare, is assessing that station. When we go for station 5, you can see all 7 skills are assessed in station 5. Right. Now, how to pass with the higher score? We have to understand how these marks divided in the skills wise as well as station wise. You can see the maximum mark you can mark to each station we can get is 24, 24, 16, 28, like that. The total is 172. When it comes to pass phases, you have to score 130 or above. So in this exam, not only 130 and above, there is a pass score for each and every skill. These are predefined by the federation, and usually those things will keep around like 55 to 70, because like physical examination, the pass score is like 16. You have to get 16. And physical sign is bit low, like 11. So it depends on the statistics they have the past few years, and this skills cutoff mark will be given by the federation for each year for the passing of the skill. So you have to pass each skill. So you have to get the minimum mark, predefined mark to the each skill, plus you can have to score more than 130 to pass. For over the years of examining the phases exam, which we have seen, most of the people fail in physical science. They fail physical science. Majority of failures in the skills are in the physical science. And next is communication skills. So my advice is practice communication skills, because when it comes to our MD trainees, their physical science are very good. Sometimes they fail in the communication, because we have seen 1 mark skill failure. They score more than 130, but they fail with 1 mark, sometimes 1 mark in this one skill, like communication or physical science. Some candidates are globally weak in most of the things. So they have to redo with proper practice. But if you fail with 1 skill, 1 mark with very good pass mark, this is unlucky. So please think about these minimal cutoff marks and try to get maximum for these skills. Okay. So that's the end of my presentation. The most important thing what I said is, so this is the summary of all the skills, A, B, C, D, E, F, G. Just go through everything on the MRCP website. Just read and understand what we expect. And it can't be artificial thing. What you have to do is you have to practice these things day by day. When you in the daily clinical practice, if you do it daily, when it comes to exam, it is like your board round, or it is like your daily clinical work. So I wish you all the best, and thank you very much, SLSIM, for giving this opportunity. I invite Chandimani to proceed from here, talking to you about stations. Thank you.
Yes, thank you, Barana. Can you hear me?
Yes, we can hear you,
Yes,
Chandimani.
yes.
Okay, thank you very much, SIM, for inviting us to give this talk, and thank you, Ganaka and Priyamali, for organizing this, because I think this is a very important area that needs to be addressed. So I will quickly go through. So we've talked about the skills and the marking, and I will quickly go through station 1 to 5. So in my presentation, I'll talk a little bit about the station and how we assess in each station, and then give some important points and top tips in passing each station. So if you take station 1 and 3, so I have taken the 2 clinical examination stations together. So in each station 1 and 3, you are given 2 cases per station. So 1 from each system. So in station 1 and 3, so you have the 4 systems. So in one station you have CVS and neuro, and then you have respiratory and abdomen. So you will be asked to examine 1 from each system. So as you know, each station is 20 minutes. So you have 10 minutes to examine each system. So this is again divided as 6 minutes to examine and 4 minutes for questioning. So generally at the end of 5 minutes, the examiner will tell the candidate that there is 1 minute left. So you would know that you are coming to the end of your time. And here, if you finish before 6 minutes and you say you have completed, then the questioning will begin. But if you are within your 6 minutes, you can go back and examine. At the end of 10 minutes, the examiner will stop questioning and then move to the next case. So my tip here would be to utilize the entire time, because I see candidates, they quickly finish and they say they are done. We can see that they haven't finished, but then they say they are done. And once the questioning begins, then you cannot go back. So you have to examine, like Dr. Barana said, in a very complete, systematic manner. You can't examine haphazardly, but once you finish your complete examination, then if you want to go back and cross-check a physical sign, you can do that. So for an example, let's say you have done the cardiovascular system and you complete it, and then you want to check the pulse again. Yes, you can do that, but you must show the examiners that you have done it in a very, in the correct sequence. So these are the marking sheets, which would be actually given to you at the start of the exam. So you can see you will be marked satisfactory, borderline, or unsatisfactory. So what I want to show you is, this is the marking sheet for the respiratory system examination. And here, to get a satisfactory mark, we are expecting correct, thorough, fluent, systematic, professional technique of palpation, percussion, auscultation of the chest. So in that particular order. So it is very important that you do that. And also you will be marked for your examination skills separately. Then identifying physical signs will be marked separately, differential diagnosis, clinical judgment, and maintaining patient welfare. So I have taken a little bit from the abdomen examination. So again, professional technique for palpation and percussion for masses, organomegaly. So you have to palpate for the organomegaly, and also check ascites. So sometimes I have seen candidates having been marked down in their physical examination because they've forgotten to check for ascites. So make sure that you do the proper examination. So similarly in cardiovascular and also in neurology. So the correct order is very, very important. So once you demonstrate your examination, then your important points are, so once we ask you to tell us the abnormal physical signs, you do not give false physical signs. I think Dr. Baran also highlighted this, because the moment you give a false physical sign, then you will be marked unsatisfactory in physical sign domain. So it's very important that you do not do that. And also the cases are selected very, very carefully. All the cases have very good, obvious physical signs. If you're not sure whether something is there or not there, chances are it is not there. And then on the morning of the exam, so we check all the patients again, and then the patients are given for the exam. And again, during the exam, before the exam process, during the calibration process, the examiners, the local examiner and the overseas examiner will go through the patients. And if they are not happy, then at that point, we would even change a patient. So because of that, your physical signs are very, very obvious physical signs. And also, I think because Baran didn't mention about the calibration process, I will tell you a little bit about it here. So before all the stations, each patient is calibrated. So that means the two examiners independently examine the patients, write down the physical signs, and then they compare the notes and to see what have you found and what have I found. So if one examiner finds a physical sign and the other examiner doesn't, well, that particular physical sign will not be taken as a physical sign that needs to be identified by the candidate to score a satisfactory mark. So always the examiners will decide these are the 3 physical signs or 2 physical signs that needs to be there for you to score a satisfactory mark. Even if you miss the others, it is all right. So we don't have excellent and things like that. It's always satisfactory, borderline, and unsatisfactory. So sometimes if you feel that even though the sign is there, it's not very obvious, it will not be taken into account. So this is very, very fair in that sense. So linked marking, Barana already mentioned. So if you identify the false physical signs and then you give the differential diagnosis according to the false physical signs, still you will not be marked satisfactory, you will be marked unsatisfactory. That is because the exam is about that particular patient. So we are discussing that particular patient, not about your knowledge. But sometimes you may, for an example, let's say the patient has hepatosplenomegaly, you miss the spleen and you're going in the line of hepatomegaly, and then you, in your differential diagnosis, you also come up with the differential diagnosis or the diagnosis that this patient actually has. And you give a very good discussion. In that instance, you may be given a borderline mark, but never a satisfactory mark for your differential or the clinical judgment. So physical signs is very important. And the other important thing is, do not examine or auscultate through clothing, because in the PACES itself, one of the things is, if you examine through clothing, you will be marked unsatisfactory in your physical examination. So this generally doesn't happen in station 1 and 3 because you are very careful. But I have seen this happening in station 5 because it's a focused examination. So you quickly examine, and then you are done, and you quickly want to see the lung bases, and you auscultate through the patient's blouse or the hospital gown they are wearing. And immediately you are marked down on your physical examination skill, not your identifying physical signs. So in your station 1 and 3, I will tell you one tip. I can tell you the questions that you will be asked. So one would be, what are the abnormal physical signs? So here, unlike your MD, you do not give not pale, not icterus like that. You have to say what are the abnormal physical signs that you have found. The next question would be, what is your differential diagnosis? So you say what you plan to do, what your differential is, and then the third one would be, what is the management? And that, depending on what you say, you will be marked on your clinical judgment. So you have 4 minutes for all this, and also getting your skills assessed is actually your responsibility. So but generally the examiners will somehow try and ask you these questions during the 4 minutes. But if they don't, and if you cannot, if one of the skills haven't been assessed, then you will be marked unsatisfactory. So which again is very important when you are presenting. Once you finish your examination, when we ask you what are the abnormal physical signs, stick to the abnormal physical signs, otherwise you will be wasting time then, so that you have time for your differential diagnosis and the discussion. So I told you a little bit about linked marking, so I will skip that. Then we move on to station 2 and station 4. Now, station 2 is the history taking station. Station 4 is the communication and ethics encounters. So we'll look at the stations assessment and the important points. So in both station 2 and 4, you have the time, the 5 minutes you spend outside the station, you will be given the scenario. So read the scenario carefully. Make sure you see what we have asked you to do. In the history taking, of course, to take the history and come to a differential diagnosis. But in the communication skill, whether it's a breaking bad news or whether it is a medical error, so you need to know what we are asking you to do and go inside and do what we have asked you to do. So there are some note paper given, so you can make notes on the paper outside, and you can take these notes into the room and you can refer to it at any point. But do not take the scenario inside. The scenario should be kept outside. And once you're inside, there'll be a separate scenario for you to look at. So the timing would be, you have each encounter is 20 minutes. And you would have 14 minutes with the patient and the surrogate. So once you go in, the examiners will introduce themselves to you, introduce the surrogate, you sit down, and then you start your encounter for 14 minutes. Then you are given 1 minute to reflect. So that is the time that you gather your thoughts, because the next would be the discussion with the examiners. And then so you can even take down notes or you just think what you're going to say. And then the next 5 minutes would be the questioning by the examiners. But in these communication skills sessions, you would be marked by the time you actually, a lot of the domains you would have marked by the time you actually come to the 5 minutes. So it is the 14 minutes with the patient and the surrogate are crucial. And also try and, so if you finish early here, the questioning will not start. We will just tell you that you have this number of minutes left. And then if you say that you have finished, then the examiner, surrogate, everybody will sit in silence. And at 14 minutes, the surrogate will leave the room. So utilize the time again. And even if you had finished and suddenly you remember that you need to ask something from the surrogate, you can ask because you are within your time. So this is the marking sheet for the history taking. So you can see in the clinical communication skills, so we are expecting you to take a complete history where you go through the presenting complaint, history of the presenting complaint, where you do the symptom analysis. Systemic review is very important because I think as MD candidates, you have a little bit forgotten about it because you actually cover everything everywhere else. But in MRCP places, because this is really an entry exam in the UK, so ask the systemic review, past medical history, family history, medication history, and you have to do this in a very thorough, fluent, and professional manner. So this is very important. So like Barana said, don't do the fill in blank thing that is for your long case MD. You have to show that you are asking, and it is a communication. You are assessed on your communication ability with the patient. And this is very important. Assess the impact of symptoms on patients' occupation, lifestyle, and activities of daily living. This may not be so important in the Sri Lankan setting because we ourselves don't do much about the social aspect of the patient. So that the social looking after the patient, all of that is really the burden of the family in Sri Lanka. But here in the UK, the patients are, this part becomes very important because the patients are not sent home until all their care packages and everything is in place. So this is why that this particular aspect is important in this exam, because this is a UK based exam. So so if the patient has trouble, if the patient is very breathless, if he has trouble going to the shops, doing his groceries, doing his day-to-day activities, that's a very important thing, because here the hospital will actually address those issues and start them on package of care and various things. So remember that part. And maintaining patient concerns. Now this is very, very important, skill F. So the candidates, you are expected to ask, do you have any concerns? And when the patient says their concerns, you have to address the concern. Because sometimes I have seen candidates, they ask the concerns because they want to tick that box, but then they don't address it and they're like, and then they move on. But then you must say, okay, so, and then answer their questions. Some of the candidates, they tend to ask this early on in the communication because they want to make sure that they've asked it. So when the patient says something, then obviously they don't have the answer because they haven't taken the complete history yet. At that time, what you can do is you can say, yes, let me ask you a few more questions and I will come back and address the questions you had. And then you go on with your communication and then you go back and answer the concerns at that point. So our surrogates, what we use in the local places, are very well rehearsed. So they know what they are supposed to say. So don't worry too much about the exam point of view. You just, if you sort of stick to this, you will be fine. So then, so skill C, F, G will be assessed while you are actually doing the history taking session, and including clinical judgment here, because you are expected to tell something to the patient about your plan of management, and then you and the patient should agree on that management. It's very important because unless the patient agrees with your plan, then you don't go ahead with the plan. So basically what is left for the encounter with the examiner would be your differential diagnosis. And if you haven't come up with if we are not clear about the plan that you made with the patient, then we would ask that from you again. This is in history taking. Station 4, communication skills. Again, like I said, so make sure that you know what you are supposed to say. Whether you are supposed to pacify an angry patient, or whether the patient is going to file a complaint, or whether it is breaking bad news, whatever, then you be clear as to what you need to do. And then you can come, once you come in, then you start your consultation with the patient. So the important points about station 2 and 4 are: read the scenario carefully, see the tasks you've been asked to do not rush. There is plenty of time. You know, this time, I mean, sometimes the candidates stop and they are waiting. We are all waiting in silence. And even the surrogates later on, they tell us, you know, can't you ask more things, because it's just, because there is nothing left to do. So you plenty of time. So take your time and do the communication properly. And you will be given a reminder at 12 minutes so that you know that you have 2 minutes left. So maybe during that time, so you can sort of summarize and come to a plan with the patient, but take your time and do the scenario. And only one examiner will ask questions from you, but both examiners will be marking. And also one other thing I forgot to mention was, when it comes to ethics and communication skills, sometimes some patients, if the patient is angry, or if they're upset about some management that has taken in place, and then I have seen some candidates, they say, oh, if you want to complain, you can complain. Yes, they are entitled to complain, but please don't broach on this until the surrogate or the patient himself says that they want to complain. If they say that, then you assist that. But otherwise, you yourself do not volunteer on that. And also know the principles of the ethics and which one that is asked in this scenario. So sometimes in the ethics and communication, during our 5 minutes encounter with the candidate, we ask you, so what ethical principle was addressed in this scenario? And I'm sure you know about duty of candor. So where you need to be very honest. So there are scenarios where the medical team has administered the wrong antibiotic, or has missed a dose or something like that. So during that, so if the scenario is that, then you need to be honest about it and then inform the surrogate about that. And always when you're doing the communication skills, make eye contact with the surrogate. So you are assessed on your body language, your posturing. So you don't stand back and then with your arms folded like that. It's nicer if you lean forward a little bit towards the surrogate, you look at the surrogate, you make eye contact and you listen. Because let them talk, that's very important. The first few minutes, let them talk, you listen. Although you have the scenario, although you know what they're going to say, but you at least pretend to listen, and then you nod appropriately, and and then you show empathy. So what I mean by showing empathy is, if there is an emotion like an anger or sadness or what they're demonstrating, you acknowledge that emotion. Okay, that is how you show empathy. So you can say, I'm very sorry you feel that way. And if you're breaking bad news, you can say it is a lot to take on. Or you you can say, I understand why you feel that way. So like that, and always look at them and be honest. And you have to apologize if a mistake has been made, but don't apologize unnecessarily. But if there's a mistake on your part, you must apologize. And Other thing is, do not use medical terms. So candidates, they come and say there's a tumor, there's a mass, so do not use that. This is because we don't really do this with our patients when we talk in Sinhalese or in Tamil, but unfortunately we don't communicate much in English with our patients, so then we don't have we don't know the words to use. So you need to practice a little bit. If you find an English speaking patient, practice your communication with them. And also, you can practice on your own so that you don't use medical jargon. So the examiners are very, very particular about it, especially the overseas examiner. Sometimes as the local examiner, we can understand what the candidate is saying, but the overseas examiners, they can't understand also. So make sure you do not use medical jargon. And about breaking bad news, it's good practice to always ask whether they want a family member with them. It's true, it is. They are not going to say they want a family member and then the exam is not going to happen, but always ask that. So you will be marked on that, because that is something we generally ask here. I mean, we always ask the patient, do you want to know now? Or would you like somebody being present when we are discussing your CT scan findings with you or something like that? And then they would say, and I put this term here, do not wag your finger at them. So this one candidate actually did that and she was marked down. So this, I think in Sri Lanka, we tend to do this. So do not do that. So keep your hands on your lap or, but don't do things like that. And also have an agreed ending. So always with a patient, when we communicate with a patient at the end, we come to a plan with the patient. This happens in every single encounter in the UK, but in Sri Lanka, it's a little bit different because the patients do tend to tell us, do what you think is best. Here also they do, but then you agree to, so you say, okay, so we will do these tests and then we will do this. And is that all right? And then, so like that, so you have to come to an agreed plan and also find out what the patient has understood also. So that is also very important, because you may be saying, but the patient may not have understood. So you can ask, and then you can ask, can you tell me what you have understood so far, or something like that. And also, it's also good when you are breaking bad news or something similar to ask, can you tell me a little bit about what you understand so far about your condition? So that way you know what the patient knows or the surrogate knows, and then you can start from at that point. Right. So station 5 is a very important station because all the skills are assessed in this particular station. So both the scenarios are given together, BCC 1 and BCC 2 outside when you are seated. So please remember this. I mean, last time when we had the exam, one candidate walked into the exam hall and he has read only one scenario. So he had no idea what the second scenario was. So both are given together outside. So read both. You can make your notes and you can bring your notes inside. A second copy of the scenario is in the examination room, to which you can refer to. So we always we generally start with BCC 1, unless the patient has gone to the washroom or something like that, but it's always with BCC 1. And you will have 8 minutes with the patient and 2 minutes with the examiner. And at 6 minutes, the examiner will tell you that 2 minutes are left. So you have an idea about the time. So when the examiner says you have 2 minutes left, it is good practice to ask about patient's concerns at this point if you haven't done so already. I mean, if you've done it, it's fine. Because unless you particularly ask that question, we cannot mark you on patient concerns. And once you ask, like I said before, do address the patient concern. And at the when you finish your BCC 1, and then at the end of 10 minutes, you move to BCC 2. At the start of BCC 2, quickly read the scenario again, just to refresh your memory, or refer to your notes before you start. And here, unlike your history taking and examination skills like station 1, 3, and 2, Here you are taking a focused history taking. So here you are just taking the very important bits and doing a focused examination. So bits and pieces of different important signs. So this is really like a little clinic consultation that actually happens. And you can examine while taking the history, because otherwise you may run out of time. So you ask a couple of, so the patient will also come and tell you a little bit. You ask a couple of questions so you know where this is going, and you can examine while you are taking the history. But again here, do not examine through clothing just because you are in a rush, because if you do, then your skill A or your physical examination will be marked unsatisfactory. So this is the mark sheet for the BCCs. So you are marked in all ones. So clinical communication. So here, how you take the history and how you assess that. And then the physical examination. So here, when we are calibrating for each scenario, that means the examiners, we would say these are the areas that you need to examine. For an example, if you have a patient with a thyroid problem, either hyperthyroid or hypothyroid, we would say, so in the clinical communication, the symptoms is very important, because here, like Barana said, a lot of people, they see the patient, they immediately know the diagnosis, so they think they are all right. So I can still remember in a thyroid case, a lot of candidates were marked down in clinical communication because they didn't ask for the symptoms of thyroid disease, because that's very important. That is the problem that the patient has. And also physical examination. So we would say examine the thyroid gland. So if you are, then you have to do the proper examination, look for retrosternal extension, bruit. So those are very, very important. And then you may check the pulse. So like that, then the relevant physical examination. Then clinical judgment. Again, you will be marked already, because you would actually talk to the patient about what their condition is, and then how you are going to plan. And at managing patient concerns also, we would be already marked, because you will be talking to the patient. So once you finish your, once you finish your BCC, we would have already the C, A, E, F will already be marked. So we would ask you about what are the abnormal physical signs, and what is the differential diagnosis, and maintaining, and then we would already mark you on maintaining patient welfare. So only 2 questions will be asked from you at the end of your BCC 1 and 2, because you would have been marked on everything else during your candidate patient encounter. Right, so those are a brief outline of the 5 stations. So finally, what I want to say is PACES is a very easy exam to pass, because honestly, I have not come across a more fair and really thought out exam than MRCP PACES. And the really trick to passing is, if you will and truly understand the exam, it is very easy to pass this exam. Because you are not marked on your overall appearance or your ability to speak English well. You're not marked on any of those things. You're marked on the clinical skills, the 7 clinical skills that we spoke about. So thank you very much, and good luck for the exam.
Thank you, Chandimani and all 3 speakers. Even though we are running behind the time, we can allow 2-3 questions, and we can unmute you all. You can ask few questions if you want, or you can write in the chat box where the 3 speakers can answer. Initial questions from the previous MRCP one, and the last 3 questions for this.
Yes, so there are a couple of questions I actually answered online also. So will they reimburse the money of MRCP PACES exam if we fail doing it in UK rather than in Sri Lanka? Well, they will not do that. And is there?
Shall I make a comment, Chandimani? So
Yes.
what we have on behalf of Lalisa and all of the team, what we handle is the clinical examination only. All the administrative work, you are applying to UK, you are sending your money to UK, and your slots allocation, the preference list, everything done by the MRCP Central Office Candidate Services. They give the candidates to us, then we will examine and we will send them back your results. That's what we do. Thank you.
It's nowhere any station they refund your money if you fail. This is just you lost your money, but you get some experience, and you have to apply for the next one with after finding the money. There are a few questions. I think the one appeared here. This is in station 5. Will there be an issue with translation?
No, because so all our what we have done was most of the station 5 stations we would have a surrogate with the patient. So as candidates you are supposed to communicate in English. If you don't communicate in English, the examiner, overseas examiner, cannot understand you. So if we don't have an English speaking patient in station 5, we would have a surrogate there, and that would be introduced as this patient's brother or sister or something like that. And then we would say, you can take the history from the sister or the brother. So, and then examine the patient. And also there will be a nursing officer there. So if you want the patient, you know, so things, little things like lift your hand and things like that, obviously you can, a lot of the candidates do say it in their native language, which is fine. The examiners are also not too bothered about it. But if you want to ask a particular question that you want the exam, like when you are examining and you want the examiners also to understand what you are asking, you can tell that in English to the nurse, and then that nurse will communicate to the patient, and so that the patient can do that. So do not worry about the language, because we have really looked into all those aspects and all those things are sorted.
Yeah, in the station 1 and 3, you can talk in Sinhala. That means, as Chandimani said, you can ask instructions like, I'm going to, like, Mama wagi chest me husma ganna hondata e wage kiyala kiyanna puluwan. So that's the usual thing, because there is a local examiner. So local examiner understands what you are telling. You can't ask the diagnosis from the patient in Sinhala because the local examiner is there. So basically, the station 5, as Chandimani says, station 1 and 3, because some of these patients can't understand English. So you can tell the patient, I'm the mama papuwa balanna hadanne e wage kiyala, you can tell. So that is allowed.
I can now one question, Chandimani, it's there. They are asking, what is the pass rate in Sri Lanka? Sri Lankan Center, what is the pass rate? If you, I think after that, if you can answer the chat box, that would be good.
I think the pass rate wise.
Somebody is asking.
Yeah, it's like this. It differs. It differs because sometimes we have overseas candidates also. It's coming like out of 45, like 35 Sri Lankans and 10. Some of these candidates coming from overseas are not good. So sometimes our pass rate is bit down. But when you take you compare with the general MRCP pass rate, Sri Lankan Colombo Center pass rate is higher than the overall the pass rate, overall international pass rate. So that's what I can't say figures. That is confidential, right?
Thank you, sir. Lanitha Jaratna, sir. Thank you very much for joining with us, and Chandimani from very early morning from UK and the Parana. So we'll move to the other one. Thank you all three speakers. So the next talk is peer mentoring and overseas training. It's, we have been talking about the peer mentoring earlier also. It's a form of mentorship that usually taken places between a person who has lived through that experience, specific experience, who is a mentor, and a person who is new to that experience, a mentee. And we have 2 young internists just returned from overseas, Dr. Isuru Kahandavarachi from Australia and Dr. Keshani Samarasekara from United Kingdom. And our moderator is our most energetic council member, Dr. Jagat Pushpakumar, internist, and he will moderate the session. So you all can put the question to the chat box, or I can allow a few minutes to answer the question at the end of the thing. Over to you, Jagat.
Hi, good afternoon, Dr. Premali. Hello, can you hear me?
Yes, we can hear you.
Yes, we can.
Right. Okay. So, good afternoon to everyone, and thank you very much for the kind words of introduction, even though I do not agree with the last bit, because I'm not the most energetic man in the council anyway. Right. So this is maybe the penultimate segment of the today's program, Precongress 2. So in this part, we are going to have a bit of a live discussion or chat with 2 new consultants who recently came back from the UK and Australia. So, right. So first of all, let me thank the college for introducing this segment into the Precongress 2. Because this is very important part, because when I planned for my overseas training, I had a bit of issue because there was no proper guidance how to get ready and how you should proceed with overseas training. There was some sort of document or leaflet that was going, one person to another person, and somebody is editing and like that. So there was, I mean, it was helpful, but it was probably obsolete now, because things have been changed. Keshni, can I ask you to stop screen sharing for a while? Is that okay? I'm really sorry about that.
No, that's fine.
Right, thank you. So, Keshni Samara Sekara, he is she is MBBS, MD Medicine, and she recently returned from the UK after her overseas training, and congratulations on successful completion of overseas training. So we will be, the next 1 hour, we will be having a live discussion on how you had your overseas training and how you got trained and everything. So we will have 20 minutes with Keshini, and then another 20 minutes with the next speaker, who is Dr. Isuru Kahandavarachi, MBBS, MD Medicine, and MRCP. He is currently working at a base hospital, Padavia. I'm very proud to say that that was my native place, even though I'm working in some other part of the country. So thank you for both accepting the invitation from the college. Right, Keshini, can you tell us how you prepared once you got through your MD Part 2 exam? You know that you're going to have your overseas examination in next 1 year or so, and then how you prepared initially. Just tell us that.
Yes, first of all, I would like to thank the college for this opportunity for me to present at this forum, and Dr. Jagat for that kind introduction. So immediately after passing MD Part 2, I started preparing for the overseas training experience, because there's a very limited time for us, about 1 year as general medicine SRs, to prepare for the overseas training. So as a first step, I think it's best to clear the English examination. So you have the option of doing either IELTS or OET. I personally chose to do IELTS. And depending on your personal choice, you might decide to do either. But IELTS is a little less expensive than OET as far as I'm aware. And it's a very straightforward and simple examination. If you prepare properly, you can clear it with the required scores in a single attempt. What I would recommend usually to anybody who asks me is to practice the writing skills, because we are used to academic writing, and especially if you have not done any non-scholarly writing before this, it's better to prepare for the writing component. And there's a lot of resources available online, so you can sort of get the required resources, download them from the internet. And then after clearing your IELTS, you could proceed to applying for GMC. You can do several things in parallel, actually. You can start searching for jobs, and then you can apply for your GMC registration simultaneously. Let me share my screen. So when you're looking for training opportunities, there are several different pathways that are quite useful. The MTI pathway is organized by the Ceylon College of Physicians in collaboration with the Royal College of Physicians. And then you can also try to directly apply for vacancies listed on different recruitment sites. The commonly used ones would be the NHS Jobs website and the Track Jobs site. And you can ask seniors and colleagues who are currently working abroad about any vacancies available in the places that they are working. I personally use the Track Jobs website because it's very useful. You can apply for multiple positions at the same time. Simultaneously, you can get your GMC registration while you're searching for jobs, because getting all these approvals and things take some time. So it's better to start early to allow enough time for all of that. So for GMC registration, our MD medicine qualification is accepted as an acceptable postgraduate qualification. And we would need to prepare these things prior to applying for that. So out of these, the EPIC profile is, it usually takes some time to set up the profile and get your qualifications verified independently through your university and through PGIM. And you need to make some payments for these as well. So it's better to prepare beforehand and do this early on. And then obviously you need to clear your IELTS OET to demonstrate your knowledge of English. And with regards to your passport as well, if your passport is due to expire within the next couple of years while you are in training, it might be sensible to renew it prior to leaving for UK. Because it's a bit of a complex process if you want to renew it while you're in UK. And you need to also get a certificate of good standing from SLMC. If I remember right, it's valid for 3 months or 6 months. I'm not sure, I have to check that. So you have to time it properly to get GMC registration. And also you need to get, sort of gather all these details about your past experience and prepare to answer a few questions about your fitness to practice when you're filling up the application for GMC registration. And you should also be prepared to pay the registration fees, which is a little over £400 at the moment. And the application process for GMC registration is fairly straightforward. They have a very detailed guidance on their website, and you can read that and prepare all the documents and other evidence that you require. And then you need to apply through their website, and they will send you an email telling you what are the documents that you need to provide. You need to put all of these into one PDF file and send it back, and they will review it and let you know within 5 days what are the other documents they may require. And if they've got all the documents to a satisfactory point, they will let you know that your process is complete and invite you for an ID check appointment. So during the time that I got my GMC registration, because of COVID, we didn't have to attend a face-to-face ID check. So I could get the GMC registration without having to go to UK. But currently, I think they've resumed the face-to-face ID check process. So it's better to time this application in such a way that you are able to go for your overseas training within 6 months, so that you can attend ID check while you are in the UK. So this is a brief overview of the initial preparation. And then when applying for jobs, you also need to prepare the CV for that. And you can do that online on the Track Jobs website. Like I said before, I personally use this website for applying for jobs as well. So once you sort of develop the CV on the site, you can use the same information in filling out your application. So it makes the process a lot more faster and convenient as well. So you can create a profile by entering your contact details. And once you've created a profile, you have the opportunity to build up your CV on it. So just like any other platform, it's fairly straightforward. So you enter all your information, and it is you can update it as and when necessary. And you can put your qualifications and employment experience. And also when applying for jobs in the UK, if you want your application to stand out from the rest, you will need some experience in research and publications, and also some experience in leadership and team working as well. So it's helpful if you demonstrate these on the CV itself, because then the chances of you getting shortlisted for a good position is much higher, because your application stands out from the rest. And once you have applied for jobs and if you get shortlisted, they will inform you via email. And the interview process usually takes place via MS Teams remotely. They will let you know the time beforehand. So it's very important to make sure that you prepare a calm environment where you can sit and peacefully do the interview without any interruptions. Most of the questions that are asked are quite straightforward. So if you answer sensibly and honestly, it's easy to be successful at these interviews. The panel would usually consist of 2 consultants. Usually one of them would be the clinical lead of the department, and then another senior consultant. And they will also have a manager from the human resources department also in the interview panel. The usual structure of the interview, this of course may vary from different hospital to hospital, but in general, they all follow the same structure. So usually they would start with introductions. So the panel would introduce themselves, and they would ask you to introduce yourself. And usually it goes like a pleasant discussion about your experience. So it gives you an opportunity to demonstrate your clinical experience. And if you have any research and publications, you can discuss about that. And then they would usually give you a clinical scenario and ask you a few questions based on that. It's usually a kind of clinical scenario that you would encounter on a daily basis. So there's nothing like, it won't be very complex. It's something very straightforward, like a patient coming with acute shortness of breath, or a chest pain, or somebody with sepsis, or something similar like that. And then based on your answers, they would ask you a few further questions. So afterwards, there will be another question on an ethical scenario. Again, if you have done your MRCP papers, you would have prepared for most of these scenarios for that. So I'm sure it will be quite easy to tackle that situation as well. So in that, you need to show that you are aware of the ethical principles and aware of the GMC good medical practice guidelines, and demonstrate your knowledge about the ethics system in the UK as well, which is mostly similar to what we practice in Sri Lanka as well. And then at the end, some of the interview panels may ask questions like, tell us about your strengths and weaknesses. And then some of them might be interested in things, your interests other than medicine. So it's better to prepare to answer for these questions as well. You may or may not get asked these questions depending on the time that is available for the interview. And at the end, they would give you an opportunity for you to make any questions or clarifications. The usual interview lasts for about half an hour. And it's usually a very non-threatening kind of environment. So I'm sure most of our trainees would easily get through interviews when they apply for jobs.
Right. Thank you, Keshini. And can I disturb you for a while? Is that okay?
Of course, yes.
Right. So, I mean, there are different types of interviews. They normally conduct like online interviews like via Zoom, or they have physical interviews as well. What sort of interview did you have?
So I had these interviews online via Teams because I applied directly, not through the MTI process. But I understand that if you apply via the MTI process, there will be face-to-face interviews as well.
Are you aware that the PGIM and the CCP in collaboration, they are conducting job interviews for the doctors who newly passed MD Part 2? So
Yes,
that's another way of, that's another way of getting, setting up for these interviews as well. Anyway, thank you very much for that. And then, so once, let's say you pass, you got through the interview and you got the job, and then you're packing now to leave the country. So what are the things that you should be looking for or should be paying in attention in advance, for example, like accommodation? How do you find all those things?
So there are several different ways to find accommodation in the UK. And also depending on your requirement, it might be different. For example, if you're traveling alone versus if you're traveling with your family or extended family, the requirement would differ. Some of the hospitals provide accommodation for their staff members. There's a limited amount of facilities available in these hospitals, but most of the hospital accommodation would be for that's usually single accommodation. So if you're planning to go with your family or to bring down your extended family, it's not a very good idea to go for hospital accommodation, in which case you might have to find accommodation on your own. So for that, there's various different websites, which, for example, there's one called Rightmove, another one called Supla. So there's different sites from which you can search for houses, and then there will be some referencing checks happening afterwards. You can let the house. Otherwise, if it becomes really difficult to find a house, because sometimes for some of these checks, you need to have a UK bank account and you read all sorts of letters for credit checks and things like that. So if you are struggling to do that, some people might stay with a friend or a relative in the initial phase and then find houses after they go to the UK. So there's always various different options you can explore with regards to finding accommodation.
Yeah, superb. So do you have to take anything special when you leave? For example, any documents or anything special that you should take with you, because you won't come back, you can't come back like what you are doing in Sri Lanka. So is there anything special that you must carry with you?
I would recommend carrying the originals of your birth certificates, and if you've got English translations of those, your marriage certificate, and if you've got children, their birth certificates as well. And the educational certificates also, it might be useful because if you are intending to change jobs, because some people tend to work in one trust for a certain period of time and then change over to a different trust later on, in which case you might need your educational certificates again. So it might be sensible to take all of them with you when you're going. And then you have these other documents that you require for your visa, for example, the TB testing certificate and your IELTS certificate, and there's certain trusts require you to do some screening tests like hepatitis B and HIV. So it might be sensible to carry the original reports of these tests as well when you go. So I would think that those are the documents that you need to carry when you go to UK.
Brilliant. Yeah, it's good to carry out all your health related documents, but even though you carry everything what you have in Sri Lanka, they will definitely do your occupational health check there. But that is a matter, of course, you need to carry what you have, especially as you said, the English translations of basic documents like, your birth certificate, marriage certificate, and all those things. These things are important when you apply for, like, for example, Schengen visa or other visas, because they will ask. And even I can remember when I was applying for Schengen visa at some time, they asked for single version of the original certificate. I don't know, they can't understand anything, but still they ask that. So likewise, it's better to carry what you need, as you said. So suppose you had a job and then you successfully travel and you landed there, and then you are a doctor there. So tell us about the NHS system, like in Sri Lankan health system, the UK we call NHS system. So, the arrangement and how you get on with the system there.
So yes, to give a brief overview of the NHS system, so just like in Sri Lanka, healthcare is free of charge to the public of the UK. It is a very well organized system, I would say, because the patient would initially, the first point of contact for the patient would be their GP, and then the GP would direct them to the relevant specialties or to the hospital. Of course, if it's an emergency, they can directly present to the hospital. And when they come to the hospital as an emergency, they would first be evaluated by the A&E department, the Accident and Emergency Department, and they would triage them according to the relevant specialty. And in addition to that, there will be patients coming in as direct GP referrals. If they're relatively stable, they would come in directly as a GP referral under the care of the medical team. So those are some of the ways how you get patients to your under the medical team. And there's a few differences in the UK setup, the hospital setup, compared to the Sri Lankan setup. The operational design is slightly different. And of course, even within the UK, from trust to trust, there will be differences between the operational design in the sense that the way that you refer patients to different specialties would be different. And the way you contact different specialties via bleeps or via referral phones. So there'll be slight differences, but you will soon get used to it once you start working there. And also one important thing to mention is most of the medical records are electronic. So everything you do, the documentation and ordering blood tests, writing discharge summaries, all of these will happen on an electronic platform. And most of the hospitals will have more facilities compared to the hospitals in Sri Lanka. In the picture on the slide, I have shown the hospital where I worked, which is the University College London Hospital, which is considered to be one of the best hospitals in the UK. So they had all the state-of-the-art facilities, which make your life a lot easier because you have easy access to all the investigations at the click of a button. So at the beginning of your training, you will have an induction period where you will be shown around the department and introduced to the staff members. And you will get a formal training on using electronic medical records. It takes us a little bit of time to get adapted to the electronic medical records because we have been using paper-based records all our lives. But once you get used to it, you will find that it's very easy when you work with medical records electronically. You will also get, during your induction period, you will also get the opportunity to shadow a registrar who's already there. So you get the hang of how the referral system and things work. So initially with all of these changes, it will take you a few weeks to get adapted to that system. But once you get adapted, it's very well streamlined and it's very well organized. So it's quite easy to work there. And there's a few responsibilities of a medical registrar. And the take, that's what they call the medical patients that come in through the NE is called the take. So it's the on-call medical registrar who holds the referral phone or the bleep, and they will accept or sometimes refuse the referrals that you get from A&E. And but when I say refuse, what I mean is you redirect them to a more appropriate specialty. Like if they try to refer you an acute abdomen, you'd have to tell them this is a surgical abdomen, refer it to the surgeon. So sometimes those instances might also occur. So it's the registrar who accepts these patients and maintain a list. And then at the handover, at the end of your shift, you hand it over to the next registrar. Usually during normal working hours, there will be a consultant on site. So you could go to them with any questions you have. But after 5 o'clock, you would be the senior most person in the medical team on site. There's an on-call consultant whom you can reach over the phone at any point if you require any advice. Ward rounds, again, will vary depending on the different units that you work. Usually the consultants tend to see the new admissions and complex patients, and you will be seeing the rest of the patients. And you will have an intern, they call interns as FY1s. So an FY1 or a SHO scribing for you, so it makes things easier for you. But sometimes when there's staff shortages, there are times when you need to document for yourself. So it is quite useful if you are well conversant with the electronic health record system, because it speeds up the documentation process. Otherwise, it will take a very long time for all the documentation. clinics in the UK are relatively less busy than the clinics we have in Sri Lanka. You've got plenty of time allocated per patient, and most of the referrals come through the GPs. So you need to evaluate the patient and then make a plan. In the initial stages, it's better to discuss it with your consultant, but as you gain more experience, you can make a plan on your own and then write a referral letter back to the GP with your plan, with suggestions that you've made. And then there's opportunities to do procedures as well. Most of the internal medicine trainees in the UK are quite keen on doing these procedures themselves because they need to fill up their portfolios. So you will have to sometimes supervise them and sort of troubleshoot when they come across troubles. The common procedures are similar to what we do in Sri Lanka, like lumbar punctures, acidic drains, chest drains, and ultrasound guided cannulation. All the drains are also done under ultrasound guidance in the UK, and it's quite straightforward, and I would say it's easier when you do it under ultrasound guidance. But if you're not familiar with using the ultrasound machine, it might make sense to attend a training program prior to going to UK to make sure you are conversant with how to identify things using the ultrasound scanner. And then as the medical registrar on call, you are responsible for leading the cardiac arrest calls and medical emergency team calls. So it's worthwhile sort of revising and refreshing your knowledge on managing a cardiac arrest, especially in light of COVID. There were certain differences that were introduced to the algorithm, and also refreshing your knowledge about medical emergencies, because you will be the one who's leading the team at medical emergencies. So this is a brief overview, and obviously at the end, I'm happy to answer any more questions if you have any about the role and responsibilities.
That's great. Thank you, Keshini. And a couple of things to add to what we're talking up to now. Of course, in the UK, when you're practicing as a registrar, you need to have a validated ALS certificate, right? For example, like we have what is in ERC here. Which is a European Resuscitation Council that is accepted in the UK. If you have that certificate, you are accepted from the UK ALS course. Otherwise, you have to do an ALS course, and then you get through that. Then only you are supposed to work as a fully competent registrar. And also, so don't worry about the ultrasound things. We have arranged that for on the 30th for you all, right? So I know you've been working in the UK, but did you have any issues with the linguistic, language issues with them? We have got, let's say, you got your IELTS 9 and so on, but when you go to the UK, they don't know what we talk in English, right? So they have native English. So any issues you face that, or what are these young doctors should know before they leave for their overseas training?
Yes. Especially these days, there's a definite communication barrier because you wear the mask, so you cannot see how their mouth moves. So that sort of introduces an extra barrier to your communication as well. And even within the UK, there's regional variations. Like sometimes you get patients from Wales and Scotland and those areas with very thick accents. So it's very difficult to understand what they say. So in those instances, I think the best way to deal with it is to openly tell them that I find it difficult to, you have to say it politely. So you have to tell them that it's difficult for me to understand. So can you speak a bit slow, or like use some sort of communication strategy to try and understand them better. And it happens in the reverse as well, because some of the patients in the UK, especially elderly ones with hearing impairment and all, they find it difficult to comprehend our accent, especially when we are wearing masks as well. So in that case, you need to adapt different strategies. Sometimes you need to speak a bit slower than you usually do, and you will need to sort of adapt various strategies to overcome these difficulties. But over time, I guess you get used to recognizing different accents within the UK as well, and you get adapted with time.
Of course, yes. When you listen to that, monotonous or so-called native British language over the couple of months, then your ears and your brain will tune to that language, and you will be like talking to you the same way that they're talking to us. Good. I will tell you, this is not funny, but it's good to know that, because one of my friend who went before me to the UK, and then who some of the British chap has asked, what is your Christian names? And from my friend, he asked, what is your Christian name? Then my friend didn't understand that. He said, well, what is that? Sorry, I didn't get you. And he said, what is your Christian name? Then my friend took a little time, and then he was thinking, and he said, well, I'm not a Christian, I'm a Buddhist, right? So likewise, those things can happen. So Christian name, then only I got to know that Christian name is first name, which happened in the baptism. Anyway, so those things can happen, but they're not funny, but still good to know those things. Right, so same thing happens even in the ward setup as well. For example, if you ask from, have you passed urine, or sort of like if you use medical jargon, people really won't understand. For example, if you tell, how is your water work, like something like that, they will clearly understand that. Okay, right. Is there any certificate or any documents to be sent while you are having the training in the UK to the PGI mode, to the college or anything? Is there anything especially that you should be sending to?
The PGIM will give you some forms, like the quarterly appraisal forms, which you need to get filled up by your trainer in the UK. So when you work in the UK, every trainee will be assigned an educational supervisor, who's usually one of the consultants that you work with. And usually those consultants are quite, I mean, they're used to, if there have been Sri Lankans who have worked there before, they're used to these forms. Even if not, if once you explain it to them, they would happily fill them up. So in addition to that, you have the option of maintaining a Royal College of Physicians portfolio as well. So you need to pay a certain fee to get access to it, and then you can maintain that portfolio. And on that, again, there's forms like similar to the assessment forms that we get from PGIM, the ACAT forms, the CBDs, and mini clinical examination forms. So you have electronic versions of those forms on this Royal College of Physicians portfolio. So you can send these forms electronically via the official email to your consultants that you work with, and then you can get the assessment done through them. That's a very good form of feedback as well. And sometimes, most of the times, they will write some constructive feedback for you. So that helps you to develop as a trainee as well. And the portfolio is also useful for your annual appraisal as well, because when you work in the UK, if you're planning to continue keeping your GMC registration, every 5 years, the GMC registration needs to be revalidated. And for every revalidation, you need to have done annual appraisals every year. So usually if you're working in the UK, the hospital will assign an appraiser for you, and you need to develop your portfolio with all your clinical experience and other experiences as well. Because when you work in the UK, you get opportunities to get involved in research and quality improvement projects, and you can get a few publications and presentations out of those, and you get the experience to teach, like you get to do a lot of bedside teaching, just like you do in Sri Lanka. And in addition, if you're interested, you can get involved with the relevant university. For example, the hospital that I worked was affiliated to the University College London, so I worked very closely with them sort of did some training, teaching sessions for students affiliated with the university as well. And you can also even go as examiners for their final MBBS exams. So there's a lot of opportunities there, and you can attend workshops and conferences because you get a study budget and study leave when you work in the UK. So you can utilize this for all of these continuing medical education activities. And you can get involved with clinical governance activities like morbidity and mortality meetings and internal incident discussions and things like that. So all of these experiences are useful to make a complete portfolio, including your clinical and other administrative experiences as well. And all of these are useful for the annual appraisal at the end of each year.
Thank you, Keshin, and yeah, thanks for that extensive elaboration on the experience in the UK. But I think Isuru is eagerly waiting to share his experience, what happened in the UK, Australia. Sorry, Isuru, why don't you take your time to tell us about what you had? Because I don't have any idea about Australian system. So tell us how you found your job, and then how you get into the system and you successfully completed that. And then in common, I will be asking certain general things as well at the end.
Yep, sure. Just give me a second.
I mean, the preparation after the MD part 2 is the same as UK trainee, but just elaborate, tell us on how you get Australian jobs and then opportunities, and how you proceeded with that.
Can you see the presentation?
Yeah, we can see. Yeah, go on.
Okay, right. So first of all, I'd like to thank the college for giving me this opportunity, and thank you, Dr. Jagat, for the kind introduction. Fortunately for me, Keshini sort of covered most of the things that I was actually going to say, so I wouldn't try to overlap what I'm going to say in terms of preparation, everything. In terms of preparation, while you are an SR in Sri Lanka, I would advise everyone to sort of start looking for jobs as soon as you start your senior registrar period, because from the point of you being accepted to a position in Australia to the point where you actually land, it takes about 5 to 6 months. That actually also would depend on the pathway you choose to enter Australia, but roughly it would take 5 to 6 months from the point of being accepted there. So as Keshini said, get the EPIC done, EPIC verification done early as possible, because it doesn't really has an expiry date. So it's valid lifelong. Get EPIC done, IELTS. So the benefit of OET is a bit more expensive, but they say it's a bit easier. And also for Australia, you have the PTE exam, which apparently is easier as well as a bit cheaper. But I would leave it up to you, because I'm not really very conversant on OET or PTE. Also, in terms of English exams, IELTS is only valid for 2 years, if I remember correctly.
Yeah,
so,
yes.
Yes. So if you if you do the exam a bit too early, now when it comes to Australia, if you change your hospital for the second year, you might need to change your visa status as well. So you'll need a new visa for your second year. And when they check for so when you apply for your second year's visa, they will check whether your IELTS exam is up to date. So if you do it a bit too early, it might expire before that second year of your training. So make sure you don't do it too early as well. So somewhere close to about maybe halfway along your SR period would be the ideal time to do your IELTS exam. I'm not really sure about the validity of the other 2 exams.
Right. Is there any difference between the job role in Australia when compared to UK jobs?
No. So in terms of, so I'll just give a brief overview about the PG training in Australia before I move to that question, Dr. Jagat. So in terms of the types of jobs you get in Australia, so the registrars in Australia are categorized under 2 categories, the BPTs and the ATs. So basic physician trainee and the advanced trainees. And then you have the unaccredited positions as well. So the BPT is like our registrar position, and the AT is similar to our senior registrar position. Now, apart from these 2, you have a position called the PHO, that's the Principal House Officer. It's only present in the state of Queensland, where I worked, and that's similar to a position of unaccredited registrar. Then you have the fellowships, which you don't really get it in general medicine. It's only for the subspecialties. And the other difference in Australia is that you have less access compared to the UK to tertiary care centers, because they are not really very familiar with our training in Sri Lanka. And most of our trainees have actually usually go to the base hospitals in the rural peripheral areas in Australia. Now, when you talk about the hospital system, it's essentially the same as Keshini mentioned as in the UK. However, you do have more private hospitals in Australia compared to the UK. For example, if you check across the road on any public hospital in Australia, you'll definitely find a private hospital, just like in Sri Lanka. So the patient burden on the public sector is a bit less, I would say, compared to the UK. So I worked with some colleagues from the UK who came down to Australia, and what they say is that the work stress is relatively less in Australia. The pay is good, and it's easier to work with the people. So the referrals also again come from the ED directly, and most of the referrals you get are stable patients. Otherwise, they straight away go to the ICU. And the two hospitals I worked in Australia, they mainly had a geriatric sort of population. I would say, I'm not sure how the status is in the UK. And also I should mention there's a very prominent allied healthcare input in these countries, which we are not really used to here in Sri Lanka. So you'll get a pharmacist always walking around you with the drug charts and correcting your mistakes as well, which I must say would come as a surprise to some people. And also you get a lot of input from the physiotherapists, the occupational therapists, and the social workers as well. So you get to know how well these allied health staff are integrated in the healthcare system over there, and how they sort of actively contribute to patient care. Sometimes you have multidisciplinary team meetings. We had about 2 meetings per week where all the allied health staff come and discuss patients, and they offer their valuable input towards better patient care. They also contribute much to discharge planning as well. And like Keshini said, it's computerized healthcare over there as well. So you need to start improving on your typing speeds while you join here. And in terms of clinics, as Keshini said, it's less busier in the sense that we have less number of patients. So compared to, say, a medical clinic here in Sri Lanka, which has about 200 to 300 patients, we only get about 5 to maybe about 10 patients per clinic. But you do have to spend a lot of time with each patient, which makes it busy in another way, I would say. And right, I would like to touch upon a bit about the income as well. So usually you get about $55 to $65 per hour pay. In Australia, it depends on the state. And in Victoria, it depends by the hospital as well, because in Victoria, all the hospitals are sort of privately owned, although patients can get the care freely. And it's taxed about 30%. However, you get these incentive payments in some states, especially when you are working in the rural areas as well. And when you do overtime, so usual work hour is about 76 hours for fortnight. And if you work extra, so you get so for each hour you do, you get paid about 2 to 3 times the usual rate. And you have these tax returns at the end of the year where you can claim things like maybe a phone or a laptop, things like that. Some of the tax will be returned to you at the end of each year. And especially when you're working in the health sector, you get tax exemptions for things like your rental, your house rent, and your vehicle fuel consumption and everything. So you get of course, it's not unlimited, but you get about $9,000 per year refunded back to you. Also, you have, sorry?
I hope it is not 20 liters per week like in Sri Lanka. But I think this is most important slide out of those 2 presentations, because this gives, senior registrars, please don't try to calculate, convert that to Sri Lankan rupees looking at these figures. But yeah, it's really important, guys. Money is important, as in the UK as well. So you get pretty much the same salary, but of course you get salary cut downs, all these tax and everything. So can you two tell us about briefly, other than academic, like or recreational activities or extracurricular things that you can do in the Australia and UK? So in briefly, like I'll give you like maybe 2 to 3 minutes, because we need to give some time for the senior registrar to ask some questions as well.
Okay, since I'm still having the slide shown, I'll start off with it, Keshini. So Australia is basically a continent, I would say. So you know how big it is. So there's a lot of space, a lot of So each state functions as a sort of a different country, which different sort of landscapes and environments. So the Australians are pretty laid back. They like to have fun. They like to go on trips. They like camping, swimming, fishing. So it's the ideal country in a way to explore, go on trips, get to know the areas as well. And since it's very large, you need to actually travel by flight to get into other places. There's only so much you can explore through by our vehicle. The people.
Sorry, just tell us about the driving in Australia. Do you have is Sri Lankan license accepted in there, or do you have to have Australian license?
Yes, so the driving license, it depends on each state. So where I worked in Queensland, it was the Sri Lankan driving license was valid for 2 years. But if you're planning to stay more than 2 years, you need to convert it to the local license. And in some states, it's 1 year, where after 1 year, you need to renew it. You need to get the local license. So the driving is the same as in Sri Lanka. It's a right-hand drive. And it's, of course, much more easier. But you need to stick to the rules and the speed limits as well, I would say.
Right, and we'll turn back to Keshini as well. So what's happening in the UK? Have you driven in the UK, or just tell you don't? Yeah.
Again, similar to Australia, even in the UK, the pattern of driving is quite same as in Sri Lanka. And with regards to the driver's license, if you have the older version of driver's license, which doesn't get renewed every 5 years, you need to get the international driving permit before you go to UK. That can be you can get it from the Automobile Association in Colombo, and you can use it for 1 year. And if you wish to, you can also get a UK driver's license, which I didn't get because it's a lengthy process. But you can renew your international driving permit every year, and then you can use that for driving. And also in UK, the public transport system is quite efficient, especially in central London. It doesn't make sense to use your car to go to work because the parking facilities are very limited and very expensive as well. The hospital that I worked was in Zone 1, central London, and it was an ultra low emission zone. So you need to pay the emission taxes and all of that if you're using your vehicle to go to work. So I used public transport to go to work, and the hospital network in UK is very well accessible with public transport, the buses, and in London you get the tube network. Like the hospital that I worked had 2 tube stations on either side of the hospital. So wherever you wanted to go to in London, it was very well connected to all the tube lines. It might be a bit different in the peripheries where you might need to use a car to get to work. But if you are in London, you can use public transport. And so with regards to leisure activities in the UK, you're spoiled for choice. There's so many activities. If you're an outdoor person, you can go hiking, traveling, trekking, and all sorts of activities. And if you're an indoor kind of person who likes museums and galleries in London, you've got plenty of those. And then there's all sorts of events. If you're a person who goes to concerts, drama, theatre, there's opportunities for all of that in London. And if you're into other things like painting, again, there's lots of like classes and sessions that you can attend. So there's various leisure time activities, and you get more time for leisure activities as well. And if you are a travel enthusiast, Europe is just a train ride away from London St. Pancras. You have easy access via the Eurostar trains to Europe. And then even if you don't want to take the train, you can still take flights, which are very frequent and not very expensive. So it's a very good opportunity to explore Europe as well while you're in the UK.
Fabulous. Right, I think we probably coming to the end of the session. So we'll give some time for the audience to ask some questions from you too, maybe from me as well. If we can unmute the audience so they can ask questions from Keshini or Isuru or any other queries that we haven't discussed here.
And while we are waiting questions, Jagat, there are a few questions in Q&A session. You can answer if you look at the Q&A.
So there is one asking whether we encounter medical undergraduates as well as in Sri Lanka, and whether we are supposed to teach them. Yes, definitely. We get medical students coming in Australia, and we are actually expected to teach them. And they are very, I would say, quite forward compared to our medical students. and they would sometimes ask questions, that we actually haven't even thought of. I would say that would be the similar case in UK as well, isn't it, Keshini?
Yes, you frequently encounter medical undergraduates and you get opportunities to teach them. And in addition to that, even for IMTs, there's organized teaching programs in different trusts. So they would invite you to deliver lectures and sessions in those as well. So yeah.
Somebody's asking about, please tell us about salary scales per month in Sri Lankan rupees in the UK versus Australia, right? So I think
it varies daily, every day.
Right. So it varies when the exchange rate goes up and down, but it definitely is great than it's much better than what we receive in Sri Lanka. So don't worry about salaries. You will have enough salary, enough money to survive in the UK and enjoy and go all over the world probably. What are the other questions? Isuru and Keshini, you also can go to the chat box and see whether you can.
Chat box and Q&A both.
They're asking about the cost of living. Well, I would say it's reasonable. I mean, even if you go with your family and if you have like a couple of kids, you can actually survive with one person working over there. I'm not sure about the UK though.
In the UK, again, it's highly variable depending on your individual circumstances. Say, for example, if you go with a family of a few kids, if they're schooling, there's no problem because they will go to schools and schools are free of charge. But if you have preschool level children who needs childcare, it's quite expensive in the UK. And so again, depending on your personal circumstances, if you want to live in a bigger house, obviously the house rent is higher. And again, depending on the area where you would be, if you're going to be located in central London, you're going to have a higher expenses with related to house rent and transport costs. It might be not so high in the peripheries. So it's very, I mean, I cannot give an exact figure and say this is how much you're going to spend because it's very individualized. And also depends on the amount of energy you use and things like that. So it's a very individualized thing, I would say. But it's bearable. There's no difficulty in managing your salaries because you get a good enough salary to have a very good life and enjoy yourself, like Dr. Jagat mentioned.
Right, of course, yes. There are lots of questions popping up, but I think you have answered.
I can allow you another 5 minutes.
Okay, right. So, Keshini, just tell us about, because there's some important thing when you're opening a bank account in the UK, and you may also add to Keshini. So, what are the things? Are there any banks where you can go and easy to open the bank accounts? Some banks are they're asking for a hell lot of documents, and then you just it's really.
So hectic, several different mechanisms how you can open a bank account. There are certain banks which have an institutional sort of understanding with some of the hospitals. So they might accept just the letter from the hospital to open a bank account in that particular bank. And also there's certain banks, for example, like what I personally did was I have an account at the HSBC in Sri Lanka. So because of that, because it was a HSBC Premier account, I have a personal manager here. So I spoke to him and made arrangements to open a HSBC UK bank account through that pathway. So it was sort of easier to do it that way. Because then by the time I went to the UK, I already had the bank account open for me. But it might not be the case in everyone's situation. So in that case, you will have to check with your hospital to see if they've got an understanding with any of the banks, which will help you to open a bank account. And there are certain banks which will for example, there's this online credit cards like Monzo that people frequently use, where you can deposit a certain amount of money beforehand, and then you can utilize it. It's even though it's a credit card, it's kind of similar to a debit card where you deposit the money beforehand before you use the card. So initially, until you get a bank account sorted, you can try using a Monzo card because most of the payments for like this public transport would be based on your contactless card. So it's useful to have a card as soon as you get there. So I would recommend Monzo for somebody who finds it difficult to open a bank account. And again, like I mentioned, you can use various ways to open a bank account.
Right. Thank you, Keshini. And can I ask the last question from the audience? Isuru, this is for you. There are a couple of people are asking for, is AMC relevant to practice in Australia, like a senior registrar?
Okay, so AMC is actually for international trainees when they want to come into Australia. So AMC is not a must when you are coming as a specialty trainee. So as I mentioned, actually I didn't mention it before. So there are two pathways when you want to get a job in Australia. So one is the AMC pathway, and other thing is the short-term specialty training pathway. So the short-term specialty training pathway does not require for you to do AMC. So it's a temporary sort of registration you get with the regulatory agency over there, that's APRA. So it's a 2-year temporary registration, so you don't need to do AMC for that. But if you do AMC, so as most of you would know, there are two parts. If you do part 1, you have about 6 years gap to do part 2. So within that 6 years, you can get a job as a registrar in Australia. So the main advantage of doing AMC part 1 would be you can bypass the RACP to get approval for this short-term specialty training pathway, and makes the process a bit quicker. And you can actually work there for like 6 years if the circumstances allow you. So AMC is not a must, but if you have it, it would make things easier, as well as when you are facing an interview. If you have AMC, it would be considered an added qualification as well. And also, just while I have the mic, just regarding banks, in Australia, there are 4 main banks, and most of the trainees go for the Commonwealth bank accounts when they are in Australia. But I need to tell you that the Commonwealth bank account is linked to your visa. The bank account should be withdrawn when your visa expires, so you cannot maintain your bank account in Australia once you come back here. So I would advise you to go for another bank, which allows you to maintain your bank account after you return as well.
Fabulous, Isuru. Thank you. I think that's probably from this point we can wind up the session. Thank you very much, Isuru and Keshini, for your lovely talks over the last 1 hour. And then I think you answered most of the questions from the audience as well, but there are some questions which unanswered. Of course, this 1 hour is not enough to discuss about the UK training or Australian training. It's a huge, it's 2 years process. You cannot compile, you cannot discuss that in 1 hour time. But anyway, on behalf of the college, I'm really grateful, and thank you very much for you too, spending your valuable time with us. And then please join our sessions starting from the 5th to 7th over the next coming weekend. And I wish you all the very best, and thank you very much for joining with us. And as well as senior registrars, I wish you all the very best and good luck with your overseas training. If there are any questions, please contact Isuru and Keshini. People who are going to Australia, please contact Isuru if there are any issues, and Keshini, of course, if somebody is trying to go to the UK. Right. Thank you.
Thank you, Jagat. But thank you very much, our 2 speakers, and Jagat so nicely moderating it. But I just want you 3 to see the chat box and Q&A and answer the question then and here until we go through the last lecture. So before starting that, just a kind reminder, there's a feedback Google Sheet, just fill it. And just I invite all of you to become members of the college. You can go to www.slsim.lk website and you can become a member. So before wasting much time, we have actually come to the last lecture of the session, this pre-congress. It is about the portfolio. The portfolio is a self-assessment which you write day to day and practice when you're training in Sri Lanka and UK both. So here we have invited Dr. Megan Hume, as a consultant physician in acute medicine, Gordon Hospital, UK. She's an RCP representative, and it is a collaboration with RCP here. And may I invite Megan for her lecture, apologizing for 10 minutes delay.
Good morning. Can you hear me?
Yes, we can hear you. We have afternoon here. Thank you for.
Yes, it is the afternoon. It is the morning here. Thank you very much for inviting me to speak to you. I My name is Megan Hume. I'm a locum consultant in acute medicine at the Borders General Hospital in Scotland, UK. I'm speaking from the town of Peebles, which is in the Scottish borders, just north of the border with England. So I'd like to reiterate that I have no conflict of interest in making this presentation. The images that I've used are either my own or copyright free. So what comes to mind when you think of portfolio? I know medical trainees often think of portfolio as a bit of a burden and a bore, perhaps a bit of a ball and chain that follows us through the training programme. Or is it just another example of what feels like those hoops that we all have to jump through during the training programme? My aim today is to talk to you and try and give you some tips and tricks to help you approach the portfolio efficiently, minimize the amount of time that you spend, but maximize the quality of the content, and crucially, make your portfolio work for you so that your strengths and skills and competencies are all clearly displayed to your supervisor or assessor. So I'll talk for maybe about 20 minutes. I'll pick up some key suggestions, and then at the end, hopefully we can have a bit of time for some questions if there are any. So we'll take a very short detour into my own experience. You may be wondering what makes me qualified to talk about how to get the best out of your portfolio. Well, it's maybe not the journey that you might expect, but I certainly have had a journey. So I embarked upon and completed foundation doctor training as it is in the UK, the first 2 years post-graduation from medical school. And this was my first introduction to portfolio. We used the portfolio from the Joint Royal College Physicians Training Board, that's the JRC-PTB, which is used widely for medical training in the UK. As I will allude to later on, I maybe didn't make the best use of my time on the portfolio during the foundation programme, but I did enough to get me through. I then started core medical training, now known as IMT or internal medical training. And although I really loved the job in so many ways, I felt like the training programme wasn't right for me at that time. It didn't fit with my life and the career goals that I felt I had at that time. And so I left the training programme and I took the job as a specialty doctor in general and acute medicine, sometimes known as a trust grade doctor or a staff grade. So essentially I was no longer in the training programme, and whilst appraisal was clearly still mandatory, I was not tied to the timescales of the training programme or the portfolio, and it was wonderful. It felt like a holiday. I enjoyed this freedom and flexibility to pick up on some other aspects of medical career, such as teaching, service development, which can be harder to focus on when you're in the training programme and moving across different hospital sites. Nevertheless, in time, I decided that my career goal was still to become a consultant in acute medicine. So I had to decide between returning to the training programme and what's called a CSER. That's the Certificate of Eligibility for Specialty Registration. This essentially allows you to demonstrate equivalency of training in your career and obtain a CCT, which is a Certificate of Completion of Training. And then you can go on and apply for substantive posts in the UK. Many of you, I'm sure, will be familiar with this route. It's very appealing to those doctors who have trained and practiced abroad, as they have a lot of experience, which is equivalent to the UK training programme. So when deciding between returning to training or doing a CSER, because I'm a masochist, I chose the CSER. The CSER is a real mission in documentation: logbooks, reflections, feedback from patients, feedback from colleagues, surveys. It makes the training profile sometimes feel a bit like child's play. So it was through this experience that my respect for the portfolio shifted, and I learned, often the hard way, some of these tips and tricks that I will share with you now. Number one, familiarise. So I would really urge you to become really, really well acquainted with your portfolio. I imagine there's a strong likelihood that it's an online system. Many of you may be familiar with the JRC-PTB portfolio or even using it. Even if you have a portfolio that's not online and you're collating written guidance, then spend some time, at least an hour or so, going through all of the sections, taking notes, crucially seeing how these sections link together and the overarching structure of the portfolio. When I started using Portfolio, I was quite frustrated with it. I felt that this particular portfolio wasn't very user-friendly. On reflection, I made the mistake of just using the sections that I needed at that time. So for example, if I wanted to send a ticket request to get an assessment from a colleague or to write about a teaching session, what I failed to do was appreciate this overarching structure of the portfolio and the way that you can link between the different sections. For example, if you have to link to your curriculum or you can demonstrate evidence of a procedure, you can use one piece of evidence to link it in multiple ways. So the screenshot here is of my own e-portfolio, and I've circled all the different sections as an illustration of all these different areas that you can explore and gain an appreciation for with the structure. For the first 2 years, I probably only used the first 2 or 3 of these. I've linked here to the personal library. Most electronic portfolios will have a library or a document section where you can upload, for example, CPD certificates, research papers, e-learning, teaching, etc., etc. I think this is a really valuable and probably underappreciated resource. I would suggest that each time that you obtain a certificate or proof of attendance for a conference or whatever it is, upload it straight away into your personal library or even scan in paper documents. It then allows you to really easily link to the curriculum or other sections of your training portfolio. And of course, it stands as a really useful standalone portfolio for all of your achievements, and they'll then be stored safely on the web. And you can download these back into a PDF file and use them for whatever purpose you might need. I definitely feel like I underestimated the usefulness of this section and then ended up having to go back uploading multiple things at once, which was a very tedious process. I'll go back to that. You can see here, this is the screenshot of my own personal library. Incidentally, I continued to populate this during my CSER application and submitted this portfolio as additional evidence. And this is the place where I stored all the documents, ranging from photocopies of thank you cards from patients, poster presentations, certificates of conferences, and exam certificates such as MRCP. So my next suggestion sounds a bit obvious and a bit common sense, but it's to be prepared and organised. I really think that a successful experience with training portfolio is to future-proof. And that is, for every few minutes that you spend now working on your portfolio, it'll be worth much, much more when you're scrabbling to update it in the future, potentially retrospectively, or even worse, with a looming deadline. Your future self will thank you. And there are a few key areas where I think this is especially useful: teaching, logbooks, and reflections. I'll start with logbooks. So the nature of the logbooks is likely to vary depending on what specific training program you're on, but everyone is likely to need to complete logbooks some way or another. For example, it might be the acute medical take, attendance in clinics, or perhaps procedures. The Joint Royal College Physician Training Board website has templates which can easily be downloaded by searching on their website. You don't need to be on a UK training program to use them. They're freely available to download and well worth taking a look at as an idea to how to structure your logbooks. And I've shown an example of one here. The top part of these screenshots is from the JRC PTB website. And if you search for logbooks, this is one example of one that comes up, and it's the IMT, the Internal Medical Training Calculator for acute take, clinic and procedures. And it has a built-in calculator which helps you keep track of numbers in your clinics. Remember when you're completing your logbooks to check the specific guidance for your program, but likely they will need to be entirely anonymized. Demographics such as sex and age should be left in usually, and then details about the cases. And this will help you demonstrate the depth and the breadth of your experience. During the first 6 to 8 months of taking my specialty doctor job, when I left the training program, I really enjoyed the freedom away from the structured training program, and this included logbooks. But after I decided that I wanted to go back and try to complete a CSER application, this rather came back on me. I had to go back and retrospectively complete these logbooks, which was an incredibly arduous task. I used my rota and our hospital computer systems to go back to a given date and then track all of the patients that I had seen on those dates. I then went back and transferred those into my logbook. It took many more hours than if I had completed it when I went along. I even had a colleague who was required to backdate her logbooks and had to fly 12,000 miles halfway across the other side of the world to get information to complete her logbooks retrospectively. The key is getting into the habit of recording this information on as regular basis as you can bear. At the end of the shift, I know the last thing that you really want to be doing is sitting down and logging it into your logbook. But these logbooks don't require a vast amount of details. For example, if you're in a clinic, perhaps in between the patients, you could open up an Excel file and just jot in a few brief demographics, the presenting complaint, and your plan. Personally, the way I did it is I had a file on my mobile phone. At the end of an acute take, or even halfway through, I made very brief, anonymized notes, which I could quickly then move into my logbook at a more convenient time. Even using good old pen and paper will suffice. Again, your future self will thank you. This is just an extract from one of my logbooks, and you can hopefully see that the information included is minimal, but it fulfills the required details, and it can really be used to demonstrate this depth and breadth of your experience. By the end of the CSER application, I had logbooks of over 1,500 patients covering acute take, clinics, post-take, general medicine, and it really wasn't the hellish task that I expected it to be, apart from the bit, obviously, which I already told you about when I had to collect retrospective data. Teaching. So most portfolios will absolutely expect you to complete a log of the teaching that you've been to, or indeed teaching that you've given. You'll possibly need to complete reflections on teaching as well. When I told some colleagues that I was making this presentation, a suggestion for optimizing experience with portfolio that came up a few times was related to teaching and the tip to complete your teaching logbooks as you go along. Now, the absolute optimal way to do this, and I urge you to consider this if it's appropriate, is to complete your logs while you're actually in the teaching session as you go. For example, if you're in a lecture or a session where everyone has their notes or their laptops open, you can add in the details as you're going. For example, you could be listening to me now, taking a few notes and updating your teaching logbook. So break down the time, the location, the learning objectives, and then as you're going, write up a few reflections. If it's not appropriate to do that, you're in a smaller group session or bedside teaching or similar, then aim to complete the logbook as soon as you can afterwards. The screenshot here is of a log that I took during a Royal College of Physicians of Edinburgh online event. Whilst listening to this update on assisted dying, I was able to take some notes, complete some reflections, and complete the log. And whilst the session came to a close, I had completed my teaching logbook, and it's a really efficient way of doing things. Reflections. Okay, so on to everyone's favorite activity for the portfolio, or not. I know for some people it's really the absolute pinnacle of portfolios related stress or anxiety. Reflection is a really personal thing. There's no set way to do it. There are a variety of tools which can be found online to help guide you. And I would certainly recommend that you take a look at these, especially if you find reflecting quite daunting or challenging. The specifics of these models are out with the scope of this discussion, but I think some key tips will apply. So remember, reflection can be incredibly broad. You might be choosing to reflect upon an interesting case, perhaps a significant or adverse event, a learning or a teaching encounter, management or leadership experience, or your career progression. Remember that reflection isn't just negative or neutral events. It can be positive experiences too, such as winning a prize or a positive patient outcome or feedback. When I review my trainees' portfolios in foundation training, I would estimate about 75% of all reflections are upon difficult or adverse events. This is really important, but don't limit yourself to the adverse or the negative. It's also worth remembering that reflection is not the same as, and it doesn't replace reporting of a significant event. In the United Kingdom, the GMC, the General Medical Council, has recently reiterated that they do not ask doctors to provide reflective notes as part of an investigation of a concern about a doctor. Of course, you can offer such notes as evidence of your insight into practice. And I mention this because there has been some discussion amongst UK trainees recently that a UK court of law can in fact be required to submit reflective notes to a UK court of law. And that's worth bearing in mind because it essentially reinforces the fact that reflection shouldn't really be about detail or specific facts of a case, and you should really be focusing on your learning outcomes. It's essential to anonymize all reflections, and if you think anything could be remotely identifiable, then it's really important to keep the details quite vague. And as I say, bringing it back to the portfolio, it's a really, really powerful way, reflecting is a really, really powerful way that we can link to competencies and curriculum items where maybe we haven't been able to obtain as much evidence in other ways. The example here is from a reflection that I made upon attending a roundtable discussion at a department in the hospital that I work in as part of a significant event analysis. Before I finish up, I would like to talk briefly about PDP, or personal development plans. This is usually required on an annual basis or for each job or rotation, and would be documented in your training portfolio and agreed often with your supervisor. In my experience, this is something that's quite often glossed over, but it's well worth paying some attention to. It's actually a process that I dreaded because I felt like it was just a long list of all the things that I either needed to do or hadn't yet done. But in reality, it's one of the key ways that you can make your portfolio work for you by really focusing on your educational needs, set some specific objectives, monitor the progress, and then provide evidence for it. My greatest tip would be to not shy away from PDP. It gives you a chance to look at your placement in detail, the location and the nature of the placement. So if you're moving on to a new hospital location, what are the specific specialties for this location? For example, is it a tertiary centre for cardiology or radiology? What are the hours of your placement? What's the balance between daytime and night shifts? Are you in a teaching hospital where you could take on the responsibility for teaching some medical students, for example? Is it a good opportunity to take some experience in service development? Then you could perhaps find a course or a conference which complements your goals in your PDP. If you're doing a placement in critical care, this is a great time to look at getting procedures signed off, such as central lines. And if you put that in your PDP when you're on, for example, a geriatric placement, you're going to be making your life harder for yourself, as your PDP goals need to be attainable. Focus both on short-term goals, such as being able to progress to independently putting in a chest drain, and longer-term goals, such as publishing a paper using some data collected in an audit. Remember, publishing is a long process. It's a long-term goal, perhaps one for across the training program. There are again lots of different templates to help you bring together your PDP, and these are worth exploring. All these tips will help make your PDP work for you, and in turn, help make your portfolio work for you. I hope I've managed to keep your attention in what I know many of us feel is a really tedious part of the training process, and offer you an insight that with a little bit of preparation and organisation, you really can make your portfolio work for you. The key tips are to ensure that you're very familiar and well acquainted with the structure of your portfolio. Be organised and future-proof. Committing a little bit and often now will save you time in the long run. And finally, take a break. Portfolio is not the be-all and end-all. If it's getting too much, sending you mad, making your eyes blurry, then take a break. Speak to your colleagues, your peers, and your supervisors for support and advice. That brings me to the end of what I wanted to say. So if there are any questions, I'm happy to look at those now.
Thank you, Megan. There's one question in the chat box, a Q&A. what is the advantage of MTI?
What does MTI stand for? Sorry.
I also wondering what it is.
They mean the medical training initiative, the MTI process for overseas training for Sri Lankan.
Is that one in the with the PJAM here or MTI program? There's an MTI program with the RCP and PGIM. Must be talking about that.
Yes, I am familiar with that, but it's not something that I have any specific formal knowledge of. I know that the Royal College of Edinburgh certainly has a number of international doctors that come over to the United Kingdom for a year. So, as I say, I don't have formal knowledge of that. I very often will read the feedback from those doctors that have taken part in the process, and obviously they have a great experience. So I will very briefly say that I imagine that it's a very wonderful opportunity for, the question was, what are the advantages? Is that right? What is the advantage? I think it would be a very wonderful opportunity for anybody to be able to go and work abroad. It's not something that I've done, and I would absolutely love to have done that to gain experience in different healthcare systems. I listened briefly to the talks that you had just prior to myself. It inspired me particularly to want to go and work in Australia, where everybody's more laid back, I hear. So yeah, I mean, I think the advantages are going to be enormous in terms of gaining exposure to different healthcare systems, different groups of people, patients, demographics, perhaps, depending on where you've come from. As I say, I don't know the specifics of how you apply to do it and how you would gain access to it. But I would love to think that it was available to anybody that was keen to do so. And I really enjoy reading the feedback from those of my international colleagues that have had that opportunity.
We have unmuted all, so if they have any questions, they can ask from Dr. Megan. We'll wait for a few seconds. There is, that is the only question in the chat box. And it seems there are no questions. They may have understood the things, and you have given the very descriptive, informative lecture, Megan, so people might understand that very well, and they can even go to the websites and things you have explained and get to know about this.
Absolutely. If you are using the Royal College portfolios in the UK, on their website, they have a very, very detailed step-by-step approach. Each section on the portfolio has 2 or 3 pages. You can download into a portfolio, into a PDF, and read about how to update each section. It's very, very clear. But as I said in the talk, absolutely keeping an appreciation of how all those sections link to each other is going to give you a big advantage when you're starting out.
So in the absence of questions, would like to thank Megan Hume for your excellent lecture. Thank you, Megan, for joining this early morning.
Thank you. Thank you for having me.
It concludes the second pre-congress SIMCON 22. So this is before wind up. There are a few people I need to thank. I want to thank all these speakers for their excellent speeches, and President SLSIN, Dr. Ganika Senaratne, and 2 secretaries of SLSIN, and Mr. Dishan Fernando for his excellent coordination and IT support, and Gets Pharma for the sponsoring the event, and all our virtual participants. Without you, this won't be a success. So thank you once again for joining with us. Hope to see you on 6th and 7th of this coming month in Cinnamon Grand with our main congress. Thank you very much. Have a very good evening.